so, you know, the most recent data on this slide is 2014, which is pretty old, but I did include it because it does show a significant increase in the 10 years nationally that were shown in the magnitude of 200%. What's maybe the biggest takeaway here is blood transfusion, you know, the most recent data on that. And if we were actually to exclude blood transfusions or severe blood loss or hemorrhaging from severe maternal morbidity, we would only have observed a 20% increase over that 10-year period nationally. So largely driven by individuals needing blood transfusions. And then, although this is dated back in 2014, the national rate for severe maternal morbidity was 144 per 10,000 deliveries. In Nevada, we are only trending 6 years back here, but if you compare to the 16, which is the most relevant compared to the national data, Nevada actually has a lower rate, which is 126.5. However, it has increased a little bit over time. We had 440 cases in 2021. And if we excluded blood transfusions, similarly to national metrics, we would see that rate drop to about 80 per 10,000 deliveries. So in Nevada, this is also largely driven by individuals requiring blood transfusions. When we break this down by maternal race ethnicity, we find similar disparities in the Black non-Hispanic group, also for this indicator in our Asian Pacific Islander subgroup. Those rates are 279.5 per 10,000 deliveries and 286.7 per 10,000 deliveries respectively. Again, we're suppressing our American Indian, Alaska Native and other unknown race individuals because we just did not have statistically reliable information. Here we're looking at maternal morbidity by age. You can see that there's a similar effect in our older populations, age 35 and older. We also, though, for this indicator, see increased rates of severe maternal morbidity in our younger population under the age of 20 as well. There are a total of 21 indicators that we use to identify severe maternal morbidity. 81% of the cases represented in 2021 had just one indicator present, 11% had 2 indicators present, and 8% had 3 or more indicators present. And we can look at indicators in different ways. So this slide is looking at the leading diagnosis-based indicators, and that is adult respiratory distress syndrome. Interestingly, when we dug a little bit deeper into this, we found that 59% of those were confirmed COVID-19 cases in 2021. And that's followed by sepsis, disseminated intravascular coagulation, shock, and then you'll see the rest on the screen in front of you. We can also look at procedure-based indicators. Again, blood transfusion really being the leading indicator there, followed by hysterectomy, and then some require ventilation. And this is my last slide. We are here trying to identify specific maternal demographic characteristics and prenatal and delivery characteristics that were found to be significantly associated with severe maternal morbidity. We found maternal age, maternal race ethnicity, health insurance status, adequacy of prenatal care, parity, method of delivery, plurality, or if you have twins or multiples, and then maternal chronic disease status, all having a significant impact on severe maternal morbidity. And that is the end of my data presentation. I'm happy to take questions now or at the leisure of the committee.
Thank you so much, Ms. Morgan. Are there any questions from the committee on the data specifically? And just as a reminder, we do have experts in this area presenting later on today in the following presentations, and they may be able to answer these questions either through their presentation or in the question and answer period. I do not see anybody raising their hands for questions for Ms. Morgan, but please, if I miss you, go ahead and unmute yourself. All right, not seeing any questions. Dr. Hardy, I saw you move for your mouse. Did you have a question? No? Okay. Thank you so much, Ms. Morgan. We really appreciate you presenting this data today and look forward to diving into more of the specifics on it. We're going to go ahead and close this agenda item and move on to the next presentation, which is under agenda item 5, an update from the Maternal Mortality Review Committee. And I would love to give a little history on this, but I don't remember the specifics and didn't get to dive into it. I believe in the last couple of sessions, we stood up a maternal mortality commission to look at what were the causes of death for birthing people in the state of Nevada and the statistics that are associated with those, and then come up with some solutions for us. So I'm looking forward to this presentation, seeing what we've come up with over the last couple of years since that was established. Have with us today Tammy Kahn, I believe, and she looks to be on Zoom. I'm going to go ahead and let you go ahead with your presentation when you're ready.
Great, thank you. I will share my screen. Okay, just confirming that you can see my screen.
We can, and we can hear you in Carson City.
Great, thank you. All right, my name is Tammy Kahn. I am the section manager for the maternal, child, and adolescent health section within the Division of Public and Behavioral Health. So thank you for having me here today. I will be providing an overview and an update for Nevada's Maternal Mortality Review Committee. So as Kyra already previously mentioned, within maternal mortality, there are three definitions of maternal deaths comprised in that. So pregnancy-associated deaths are the death of a person while pregnant or within 1 year of the termination of pregnancy, regardless of the cause. And then pregnancy-related deaths are the death of a person while pregnant or within 1 year from the end of the pregnancy, caused from a pregnancy complication or a chain of events initiated by pregnancy, or the aggravation of an unrelated condition from the physiologic effects of pregnancy. And then drilled down even further is a maternal death. So the death of a person while pregnant or within 42 days of the termination of the pregnancy, regardless of the duration and site of pregnancy, from any cause related to or aggravated by the pregnancy or its management. But this does not include accidental or incidental causes. So maternal mortality review committees, or MMRCs, across the country review deaths within 1 year of pregnancy. They use multiple data sources to obtain the data with the goal of using that data to drive recommendations and actions to eliminate preventable maternal mortality and to address disparities. MMRCs in the United States do support standardized nationwide data sharing on maternal deaths. So most MMRCs in the United States have shifted to using the same data collection system so that the data is standardized. MMRCs look on a case-by-case basis, and then they address the question, if they had not been pregnant, would they have died? And per the CDC, 63% of pregnancy-related deaths are preventable. The MMRCs are multidisciplinary committees. They are typically in states, but they're also found throughout cities or counties, and they perform comprehensive reviews of death among pregnant people or people within a year of the end of pregnancy. CDC does work with MMRCs nationwide to improve the review processes that inform recommendations for preventing future deaths. And like I said, most states are moving to a standardized data collection system. It's called the Maternal Mortality Review Information Application, otherwise known as MARIA. And it is a data system designed to facilitate MMRCs through collection of data. It documents committee deliberations, and it standardizes the data indicators. So Nevada's MMRC reviews the deaths of all people who died during pregnancy or within 365 days from the end of pregnancy. And we review them regardless of what the cause of death was. Our committee is required to have a minimum of 6 members, but no more than 12 members. And those members are required to be providers of healthcare, representatives of nonprofit organizations whose work is related to healthcare or pregnancy issues, representatives of agencies involved in vital statistics, law enforcement, public health, or other persons interested in maternal health and welfare. The committee should represent the racial, ethnic, linguistic, and geographic diversity of the state. The current committee members for the Nevada MMRC is Dr. Sandra Koch, and she is the chair. Dr. David Jackson, Erica Washington from Make It Work Nevada, Dr. James Alexander, Dr. Jennifer Vanderlyn, Jolena Simpson from the Kijiji Sisterhood, Dr. Joseph Adashek, Dr. Laura Knight, Melanie Reed, Melinda Hoskins, and Natalie Nicholson. So the reporting that's required of Nevada's MMRC, there's an annual report due by April 1st on maternal mortality and severe maternal morbidity, and it is published online through the Department of Health and Human Services, and that is the report that Kyra had mentioned in her presentation prior to mine. And then there is an additional report required from the MMRC biannually, and it is in even numbered years. It's due to the director of the Legislative Council Bureau, and it contains incidents of maternal mortality and severe maternal morbidity during the immediately preceding 24 months. And then it should also contain any recommendations for legislation or policy changes. And this is the report that truly captures the recommendations from the MMRC itself. So yes, the committee was established in 2020. So we've only had one report so far, which was in 2020, and then we will have an upcoming report due at the end of 2022. So I just want to go through what the recommendations were from that 2020 report. So the committee identified substance use in pregnancy and wanted to provide adequate substance use treatment options to pregnant people. So the MMRC recommended educating providers on Nevada's substance use disorder treatment options that already exist for pregnant people, and then removing any barriers to care. The MMRC wanted to address social determinants of health contributing to maternal mortality, and recommended providers consider administering a prenatal suicide screen in addition to the antepartum and postpartum depression screenings. Additionally, they wanted outreach promoting the importance of a prenatal care and preventing any delays in obtaining that prenatal care. And then two more recommendations that were just more to improve the functionality of the MMRC, one of which was addressed in Assembly Bill 287 of the 81st legislative session, and it addressed the barrier of the MMRC being able to access the Nevada Central Cancer Registry data for case abstraction. So that was already resolved in Assembly Bill 287. So we appreciate that. And then the MMRC also identified the lack of family interviews and data regarding social determinants of health. And that created a barrier to making recommendations. So they supported securing dedicated funding to ensure that qualitative data collection occurs. And I will say, doing informant interviews for MMRCs is a newer process for states nationwide. And I will talk about how we are working on that in my later slides. The other changes that have occurred for the MMRC, AB 119 of the 81st legislative session, strengthened language on identifying disparities in maternal mortality and severe maternal morbidity. So added in language for reviewing and identifying disparities in maternal mortality incidents, analyzing race, ethnicity, age, geographic region, or any other variable identified by the committee, and provided language to collaborate on the biannual report recommendations with the advisory committee of the Office of Minority Health and Equity. So I did present to the NOME Advisory Committee last year, and we have met in 2022, and we are ready to collaborate on the 2022 report that's coming up. So future opportunities for change, AB 287 of the 81st legislative session also made changes to NRS Chapter 442 to include gender neutral language, and then it also clarified the access to the cancer registry, like I previously mentioned. The gender neutral language changes did not include pregnancy throughout NRS 442, 761, and 774. And those changes only included those giving birth or those who have gave birth. So it would be important to add in the pregnancy language into that NRS. So it could read persons who are pregnant, are giving birth, or who have given birth, as used elsewhere in AB 287. The addition of including the pregnant term would just retain the MMRC's authority to request records relating to pregnancy. And then I wanted to provide a funding update. So as many of you know, we did apply for funding dedicated to our MMRC in 2019. So we applied for the Enhancing Reviews and Surveillance to Eliminate Maternal Mortality, a RAISE-MM grant. In 2019, our grant application was approved. However, it was not funded at the time. So we did begin our MMRC for the first couple of years without any dedicated funding. So July 2021, we were notified that that original application that was approved but not funded was being funded, which was great news. So the funding began late September 2021. And this funding has allowed us to hire a full-time registered nurse abstractor. Currently, our MMRC just has one part-time nurse abstractor, and that does sometimes cause issues with how long it takes to review cases, as one case can take up to just 20 hours to enter in the data into the application. So it is a timely process. And we want to make sure that we are capturing every aspect of that case to honor that person. So it allows for hiring of a full-time registered nurse, and then we're also partially funding a data evaluator. Other funding opportunities that have come up, chronic disease prevention health promotion section within DPVH has provided us with health disparity focused funding. This funding runs from the beginning of this year through May 2023. So this funding allows for the hiring of 2 MMRC Master of Social Work positions. These 2 positions will be conducting informant interviews. Like I had previously mentioned, the committee had wanted that social determinant of health qualitative data being collected. So these informant interviews will provide just such rich information on social determinants of health and other contributing factors. It'll be able to gather anything that we don't see throughout medical records. And I will just say we've been able to hire both positions, which I am grateful for. One started last month and the other person will be starting next week. And we do have to create protocols before they can begin the informant interviews, but we will get there soon. Other related efforts to the MMRC, Perinatal Quality Collaborative. So currently Nevada does not have a PQC. It could benefit greatly from having one. It can be another implementing body for MMRC recommendations, serve as a hub for our other program, Alliance for Innovation on Maternal Health, our AIM program, and would work on other perinatal efforts and improving birth outcomes. In addition, we have our Nevada AIM program. It's a national data-driven maternal safety and quality improvement initiative. We are a newer AIM state and are working towards the fall of 2022 launch of the first bundle, which is on severe hypertension. And then we also have other perinatal health initiative efforts to address key contributors to maternal mortality, such as perinatal behavioral health. And here are just some resources, links if you wanted more information. Mine and Vicki Ives, our Deputy Bureau Chief's contact information, acronyms, and that's it. I'll be happy to take any questions.
Thank you, Ms. Khan. Are there any questions from the committee? I have a couple of clarifying questions, and I believe that Ms. Gorlo has a question and Dr. Titus has a question. I'm going to start with my clarifying questions just real quick while we're fresh with the information presented. First of all, congratulations on the new hire. That is awesome. It's so good to hear. We're filling state positions. Thank you so much. My question is about the partially funded data evaluator. Can you just give us a glimpse on how are you guys partially funding, and are you leveraging with another entity that is funding the other part of that data evaluator?
Yeah, so it'll be a contracted position. We're able, just due to the amount of funding we receive, to pay 50% of that position. The other 50% of it will be paid through money from our Alliance for Innovation on Maternal Health initiatives. So both will be working, both parts of the funding works towards maternal mortality and severe maternal morbidity, but it will be 50-50 split between the two.
Fantastic. Thank you so much. Assemblywoman Gorlo, please proceed with your question.
Thank you, Chair Peters. I just had a quick clarifying question. I believe that the fetal infant mortality review just does certain counties in the state. So I just wanted to verify that the maternal morbidity review committee does cover all counties in Nevada.
Thank you, and Tammy Khan for the record. Yes, you are correct. The FEMR only goes over one county, but the Maternal Mortality Review Committee reviews deaths in the entire state. We do have representation on our committee from both north and south parts of the state to make sure that geographic diversity is representative.
Great, thank you so much.
Thank you. Dr. Titus, please go ahead.
Thank you. Thank you, Madam Chair, for the question. My question is actually along the same lines about the data evaluator. Looking at this presentation and the one prior, we get given a static set of information and percent. And what I'm hoping to hear next time or get some follow-up on you is that in the previous report we had to Clark County, there was 36 deaths in 2021 from pregnancy-related deaths. And then there's several slides later, there was some information that said 30% of deaths from pregnancy were drug-related or overdose-related. And I'm just wondering, is that to assume then 10 out of the 36 people that died during pregnancy in Clark County had drug overdoses? And so could we tease out some of that data? Because what I really am interested in seeing is that an extraordinary amount of deaths for women who are pregnant in that age of their life. So what I'm asking is, there's many different reasons that we die. Pregnancy can be one of them associated with pregnancy, but at that age group, is that an extraordinary amount of women dying pregnant versus women dying from auto accidents, women dying from accidents in home, women dying from overdose that aren't pregnant? So I'd like to see the spectrum of deaths for women in that age group and the causes of their deaths, because I'm not sure that that's an extraordinary amount of deaths based on what you're showing me on how many people live in Clark County in that age group. So hopefully your data evaluator can get more of a picture about the overall death rate for women in that age group. So thank you, Madam Chair.
Thank you for the question. Do we have Ms. Khan, do you want to respond or follow up at another time?
And I did see Kyra's camera pop on, so I didn't know if you wanted to take an opportunity first.
Sure, this is Kyra Morgan from Morgan Records with the DHHS Office of Analytics. We can surely get you that information on total deaths and then break it down by cause so that you can see kind of the umbrella that falls under. So we can provide that to the committee as a follow-up.
Great, thank you, because I really think that's the key. I mean, do we in Nevada have women dying way over the other national statistics during pregnancy versus maybe that's a low number? I mean, we don't want to see any woman die due to complications of pregnancy, but are we doing good or are we not doing good? And so I don't know, because that's just one point in time. 36 women died last year from complications of pregnancy in Clark County. How does that fall on the spectrum? So thank you. And hopefully, again, that's one of the purposes of the regulations that we passed and the NRS and doing these studies. But it only works if we kind of put it in perspective compared to other areas. So thank you. Thank you.
I appreciate. Please go ahead.
Kyra Morgan for the record. I just want to clarify that number is statewide. 36 pregnancy associated deaths were statewide, not specific to Clark County.
Okay, and your slide, it says Clark County. So on what we got, it said Clark County. So
78% of Kyra Morgan for the record, 78% of those are in Clark County.
Okay, very good.
That number is statewide.
Right, thank you. But give me a comparison nationwide. Thank you.
Thank you. I also asked staff to make sure that we had access to the document that Ms. Morgan had mentioned in her presentation. I tried to click on the link and it seemed broken. So if you have problems with it and haven't received that from staff, please let us know and we'll ensure you get that maternal mortality and severe maternal morbidity report from 2022. Are there any other questions from the committee on this particular presentation item? Go ahead, Senator Doñate.
Thank you so much, Chair Peters, and of course, Ms. Khan for presenting. My question is in regards to the policy recommendations that you proposed. It's my understanding that other states have moved towards creating implicit bias and cultural competency training for healthcare professionals that work in the perinatal space. Is that something that's required now? Do we have the ability to get certified? If I'm a healthcare professional that works in this space, do I have the ability to get certified by a state program? Or is there any requirement for me to get training in this? I'd love the chance to hear your feedback on if these conversations have taken place or where we stand.
Tammy Khan for the record. I would not be able to answer your question in regards to what is required for Nevada licensing, but I could get back with an answer on that. In terms of our committee trainings, we are planning to provide implicit bias trainings and health equity and diversity and inclusion trainings for our committee. However, we don't have any requirements for the committee.
Great, thank you.
Thank you for the question. And I believe that we have been working on some of that with within the Division of Public and Behavioral Health and their licensing division. And I'm gonna ask staff if we have anybody who potentially is coming up and to present later today, if they might be able to answer that question. But I do believe that there are existing requirements for cultural competency training for certain environments, but I'm not sure how broad that is or how specific it is to the perinatal space. So we will look into that and see if we can get an answer today. Are there any other questions from the committee on this particular topic item? Thank you so much, Ms. Khan, for attending and for presenting on this issue. We look forward to seeing your bill recommendations. And on a side note, we are looking to work session potential BDRs through this committee in July and August. So if you have ideas that you'd like to ensure get on our consideration list, please send those in earlier rather than later. You can send those into our committee email address or reach out to committee staff or myself, and we will make sure that those get on the list. Before we move on to the next agenda item, I would like to go back to agenda item 3 for a correction from our legal staff, Mr. Robbins. So we'll go ahead and open up agenda item 3 real quick for a correction.
Eric Robbins from LCB Legal. I just wanted to correct something that I said about R013-21. That regulation has indeed been adopted by the Board of Pharmacy. However, I had thought that it had been heard by the Legislative Commission and approved. It has not. It will be on the next agenda for the Legislative Commission, which is on June 10th is when they're scheduled to meet. So the regulation is not currently effective and has not been approved by the Legislative Commission.
Thank you so much. Well, we're under this agenda item. I know Dr. Titus had a question, so please go ahead with your question. And we may have to try and queue up the folks who can answer this question.
And thank you, Madam Chair. I'll reach out to them after this meeting, but just for legal. So just for my understanding, if it's been adopted, they can't enforce it, or it's not an official regulation until LegCom approves it. Is that correct?
Yes, that is correct. The regulation does not become effective until it's approved by the Legislative Commission, and the Legislative Commission does sometimes send regulations back to the agency for further further changes.
Great, thank you. So I'll reach out to my LegCom members and the Board of Pharmacy on my concerns over this regulation. We won't need to deal with that today, but thank you for the clarification. There's still hope.
Thank you, Dr. Titus. All right, we're going to, unless there are other questions that I did not get to, we're going to go ahead and move on to our next agenda item. I'm closing agenda item 3 and moving on to agenda item 6. This is a presentation on the access to maternal care and related expansion of Medicaid coverage for women. We have a few folks from state Medicaid. Please go ahead when you are ready.
A few folks from state Medicaid.
Good morning, Chair Peters, members of the committee and committee staff. For the record, I'm Dr. Antonina Capurro, and I serve as the Deputy Administrator within the Division of Healthcare Financing and Policy. We've had a small change in our presenters this morning. Miss Erin Lynch is unable to join us due to an illness. We send her our thoughts for a speedy recovery. In her place, I'm joined today by Miss Breeza Virgin, who is the Social Services Chief 1 within the Medical Programs Unit of our division. We are also pleased to have Miss Lisa Swearingen, Chief of Eligibility and Payment Units within the Division of Healthcare, of Welfare and Supportive Services, join us today. I'd like to thank you for the opportunity to present information on Medicaid coverage related to maternal health. Next slide. So we have a brief presentation this morning, and we'll be discussing statistics and covered services. We'll then move into implementation of bills from the 81st legislative session that center on maternal, child, and adolescent health, and then provide policy recommendations for future consideration. Next slide. So on this slide are some high-level statistics. The committee may recall that we had a presentation in January where we presented some of these data points. Nevada currently has 1 in 4 Nevadans that are covered by Medicaid. And you may recall that at our January presentation, we indicated that our recipient growth since the start of the public health emergency of February 2020 was 33.5%. It is now 37.2% growth. We also have nearly 30% of the state's expenditures, and we cover 55% of the births in Nevada. We also have 76% of our recipients that are covered through a managed care organization, and 42% of our enrollees are children 0 to 18 years of age. And of that, 7% are 0 to 3 years old. We also have the highest increase in our per member per month, or PMPM spend, in our infant population, where our spend has increased 26% from 2016 to 2019. Next slide. The Families First Coronavirus Response Act established a continuous Medicaid enrollment safeguard that began at the beginning of March 2020, and that will end when the federal government declares that the public health emergency has ended. But what that has illustrated here in this slide is that we've had a steady increase in our enrollment over time. Before the beginning of the public health emergency, we were consistent at around 645,000 enrollees, but you can see here month over month, we are increasing. Next slide. So turning back to births, as I mentioned, Nevada funds 55% of the births in the state, or I'm sorry, Medicaid funds 55% of Nevada's births in our state. And we're actually higher than the national average. So nationally, Medicaid covers 42% of the births in the nation. And what we've illustrated here is just how we have variations in region for that coverage. So you can see here that over time, we've had just a slight decrease in our percentage of Medicaid covered births. Clark County, slight decrease. Next slide. And then looking at Washoe and the rural areas, again, a slight decrease, but interesting to note that the rural areas have a higher percentage of births paid by Medicaid versus Washoe, and they're nearly identical to Clark County. So this illustrates, this is some of the data that we take into consideration when we're making policy decisions and when we're working to improve maternal and child health. Next slide. So I'd now like to turn the presentation over to Ms. Breeza Virgin and Ms. Lisa Swearingen, who will provide information on Medicaid's maternity care services and implementation activities for our maternal child health bills from the previous legislative session.
Thank you, Dr. Capurro. Breeza Virgin for the record. Nevada Medicaid covers medically necessary services that are within the state plan. Some maternity care services are listed in these next 2 slides, but the list is not all inclusive. Maternity care services may be provided by a physician, physician assistant, nurse midwife, or advanced practice registered nurse. These services may include prenatal visits, lab work, imaging, postpartum visits. Pregnant women with Medicaid maintain eligibility until 60 days after the pregnancy ends. Labor and delivery in multiple settings, so hospitals, home births, and freestanding birthing centers. A freestanding birthing center is a facility that's not part of a hospital, and it provides services for normal, uncomplicated births. Both home and freestanding birthing center births are appropriate for recipients with low-risk pregnancies, intended vaginal deliveries, and no reasonably foreseeable expectation of any complications. And of course, anesthesia services. The link that you find at the bottom of the slide, that is a link to our recipient booklet. And this is a booklet that we update, and we are currently working on updating to include the new services that Nevada Medicaid covers. And but this is a booklet that we do share with recipients out there in the community. Next slide, please. Additionally, we for covered services, we offer one of our newest services that we cover is doula services. And this is, and I'll go further into the details of this, but this was passed in the 81st legislation by AB 256. And so doulas, this new provider of doula and doula services became effective April 1st, 2022. With Nevada Medicaid. So a doula is a non-medical trained professional who provides education, emotional, and physical support during pregnancy, labor, delivery, and postpartum period. We are currently exploring on creating an incentive to connect women to a dental cleaning and prenatal exam, but it will be dependent on funding available. Community health worker services. Again, this policy was recently implemented as of February 1st, 2022. This is a new provider type that Nevada Medicaid has created. And that's as a result of the Assembly Bill 191 that was passed during the 81st legislative session. Community health workers are trained public health educators, improving healthcare delivery, requiring integrated and coordinated services across the continuum of health. Community health workers provide recipients culturally and linguistically appropriate health education related to disease prevention and chronic disease management to better understand their condition, responsibilities, and healthcare options. Additionally, we have dental services during the prenatal period that we cover, and these can include cleanings, preventive care, and restorative care. Behavioral health services, including substance use during pregnancy, non-emergency medical transportation to Medicaid covered services, and emergency transportation. Again, all these this list of services is not all inclusive. Next slide, please. Next, I will review these bills that passed during the 81st legislative session that are related to maternal child health. Assembly Bill 189. This bill becomes effective July 1st, 2022. And it contains two components. The first one is Medicaid presumptive eligibility for pregnant women as determined by a qualified provider. Presumptive eligibility is valid until the last day of the month, immediately following the month of enrollment, without submitting a Medicaid application. And secondly, the second component of the bill is the residency in US for Medicaid eligibility. So it allows us to remove the limitation of a pregnant woman residing in the United States for a prescribed period of time in order to be able to enroll into Medicaid. This bill is requiring a state plan amendment, and so both the Division of Healthcare Financing and Policy and the Division of Welfare and Supportive Services are working together to create that state plan amendment and to submit to CMS for review and approval. Next slide, please. Assembly Bill 191. This is the bill that allowed Nevada Medicaid to create a new provider type, which is Community Health Workers Provider Type 89, and their services. And this policy again became effective with Nevada Medicaid under Medicaid Services Manual Chapter 600, Physician Services, as of February 1st, 2022. Additionally, there is the link to the web announcement that Nevada Medicaid issued in February, which allows providers some information and guidance to how to enroll with Nevada Medicaid, as well as as well as trainings that were available as offered by Nevada Medicaid, and also some billing guidelines. And we are currently working with CMS, so the Centers for Medicare and Medicaid Services, on the state plan amendment. We continue to work with them on that. Some of the covered services that community health workers offer is guidance in attaining healthcare services, identifying recipient needs, and providing education from preventive health services to chronic disease self-management, information on health and community resources, connect recipients to preventive health services or community services to improve health outcomes, and promoting health literacy. These are just some of the services. Next slide, please. Assembly Bill 256. This bill passed our 91st legislative session, and this allowed Nevada Medicaid to create another new provider type, which is doulas, provider type 90. And this policy also resides under Medicaid Services Manual, Chapter 600, Physician Services, and it became effective April 1st, 2022. Again, there's the link to the web announcement that was issued in April that again provides billing and provider enrollment guidance. And again, we continue to work with CMS on that approval of that state plan amendment. We also, as part of this, DHCFP partnered with the Nevada Certification Board, and the Nevada Certification Board has agreed to become Nevada's doula certification body, and the hyperlink there will actually take you to their website, to the doula certification website of the board. And what they did, the Nevada Certification Board, is that they put out a request for professional doulas to submit applications, and off of all those applications that they received, they selected a group of professional doulas to be the advisory group. This advisory group started meeting in January of 2022, and they were meeting frequently, and they were really working on developing, what the requirements would be that the board would require. So what skills and what trainings the doulas must have in order for the Nevada Certification Board to certify them in Nevada. And so they began accepting applications as of April 1st, 2022, which aligned perfectly with when our policy effective date began. Doulas provide emotional support. They provide physical comfort measures during labor and delivery. They facilitate access to resources to improve health and birth-related outcomes. And doulas provide evidence-based education and guidance, such as general health practices, newborn health and behavior, and a multitude of things, of course. Next slide, please. Thank you. So Senate Bill 420, this Senate bill contained several components, but I will mention four specifically that allowed Nevada Medicaid to include in the state plan some these maternal child health services, but it is to the extent funding is available. That is the language in the bill. So the first one is the Medicaid expansion for pregnant women by increasing the federal poverty limit from 160% to 200% for this target group. This would support the continuity of coverage and care for pregnant women and their infants. Women with Medicaid are more likely to receive the adequate prenatal care when compared to uninsured women. Secondly, increasing the reimbursement rates for advanced practice registered nurse, which are our provider type 24s, certified nurse midwives, which are provider type 74s, to be equal in pay to physicians, which are provider type 20. This would allow equal pay for equal work, and it improves access to care. APRNs can fill the gap as there are not enough providers nor specialists that are able to take Medicaid at the time. And then the third one is creating a new provider type for international board certified lactation consultants. And these are non-physician healthcare professionals, but also adding coverage for breast pumps and supplies. Breast milk provides a baby with the ideal nutrition and supports growth and development. And of course, breastfeeding can also help protect baby and mom against certain illnesses and diseases. And fourth is adding non-invasive prenatal screens as a covered service. This is called NIPS for short. And so NIPS is a cell-free, non-invasive fetal DNA screening test. So it's a chromosomal screening for abnormalities. Nevada Medicaid does currently cover the first trimester, second trimester screening, which includes, these are technical terms, but trisomy 18, which is like Edwards syndrome, and trisomy 21, Down syndrome, whereas NIPS covers these in addition to trisomy 13, which is the Patel syndrome, along with sex chromosome abnormalities. So NIPS is recommended by the American College of Obstetricians and Gynecologists, ACOG, as one of the options for prenatal screenings as well. Next slide, please. And with this, I will pass it over to Dr. Antonina Capurro.
Thank you, Ms. Virgin. So I'd like to now review 3 maternal child health policy recommendations. Excuse me. The first, as we discussed during the 81st legislative session, Senate Bill 20 allowed Medicaid to include in the state plan several maternal and child health services, as we just reviewed, and these services were authorized to the extent funding is available. We've included this slide in the policy recommendation section as the division recognizes the value and the importance in implementing these services should budgetary authority be available in the next legislative session. So this is just a mirror image of those items that we discussed previously. Next slide. So I'll now introduce a policy concept that's currently being utilized by 24 states to connect healthcare to school readiness through a health examination before school entrance policy. And this policy is centered on the ideal that all Nevada children have the right to access healthcare before they enter school to improve attendance and engagement in learning. And it would include medical, dental, and mental health screening at specific age levels. So currently Nevada schools in counties with a population of 100,000 or more are required by law to provide a vision, scoliosis, and hearing screening at set intervals. So following the model of health assessments before school entrance policies in other states, this requirement could be incorporated into a broader policy that includes the completion of a medical, mental health, and dental screening before school entrance by a medical or dental personnel outside of the school. And as listed here, some of the benefits of this policy concept may include increased access to healthcare for students that may result in better attendance and more engagement in learning, a possible cost savings measure for school districts by allowing the nursing staff to be redistributed as a result of completing the current health screenings by community providers, and establishing medical, dental, and mental health homes for students. Next slide. And our last policy recommendation is a 12-month continuous coverage policy. The American Rescue Plan Act of 2021 has established a new state option that extends Medicaid and CHIP health insurance program coverage for pregnant women for 1 year following a baby's birth. So under current law, Medicaid and our Children's Health Insurance Program, pregnant women's coverage ends or it only extends until 60 days postpartum. So as you can see here, this went into effect April 1st, 2022, and it extends through March 31st, 2027, when the current statutory authority for this extended postpartum coverage option would expire. But our Centers for Medicaid and Medicare Strategies has indicated they will work with states to identify other options to maintain this extended postpartum coverage if the statutory authority to extend the coverage is not reauthorized. As extended postpartum coverage would offer Nevadans an opportunity to provide care that can reduce pregnancy-related deaths and severe maternal morbidity, would also improve continuity of care for chronic conditions such as diabetes, hypertension, cardiac conditions, substance use disorder, and depression. And the Centers for Medicare and Medicaid Services has approved this new state plan option through the American Rescue Plan for 7 states currently, and they're working with 9 additional states to complete their state plan amendments. And the state official letter, which outlines this authority, is listed there. There's a hyperlink to the document. It should be noted, though, that funding would be needed for Nevada to apply for this opportunity. Next slide. So we now stand ready for any questions that you might have.
Thank you so much for the presentation. I have Vice Chair Doñate, I believe, had a question for you. Please go ahead. No, not this one. All right, sorry, my fault. Are there any questions from the committee on this presentation? I appreciate you coming with policy recommendations, and I look forward to continuing having conversations around the funding mechanism. This is, you know, we are not limited to policy bills in this committee, but vetting those fiscal asks are difficult to do under a policy lens. So I think we could consider some of those, but we also need to digest and look at the fiscal implications and where those would come from. But I think we have the capacity to look into those over the next month or so before we work session our BDR options. I have Dr. Titus over here with a question. Please go ahead.
No, just a follow-up comment on that, Madam Chair. And I agree, having, you know, both of us have sat on this committee for a long time and certainly in sessions a number of times. And it's not against our purview to put through a policy, and then we see if it goes to, gets a fiscal note on it or not.
That is correct. That is correct. And I think that through Medicaid, because some of these are extensions of programs that you were asked to implement without funding last cycle, it would be interesting to see if you're able to build those into budgets or not, and where we need to look for what the state match or other funding mechanisms may look like. So look forward to continuing those conversations. Are there any other questions for Medicaid on this particular presentation? I have others related to some of the work being done around evidence-based services and care and continuity of care, but I'm going to take those offline with you all and see where we're at with some of those discussions. All right. Thank you so much, Dr. Capro and other folks. I really appreciate you being here for the committee and presenting on this topic area. I wanted to go back real quick. So we're going to go ahead and close this agenda item and go back real quick to Vice Chair Doñate's question about cultural competency training for medical providers. Our legal staff, Mr. Robbins, has a response to where some of the regulations are at regarding that issue.
Yes, Eric Robbins, LCB Legal for the record. So there are kind of two sets of requirements I want to talk about. The first is NRS 449.103, which requires cultural competency training for employees of any facility licensed pursuant to Chapter 449. So that's going to be your medical facilities and facilities for the dependent. And that was enacted by Senate Bill 364 and Senate Bill 470 in 2019. And pursuant to that, the Department of Health and Human Services adopted Regulation R016-20, and sections 14 through 18 of that regulation prescribe the cultural competency requirements. It basically requires new hires to receive training approved by the department in cultural competency, and prescribes the required topics for that training and the process for getting the training approved. And then the hires have to receive the training annually thereafter. The other requirement I wanted to highlight was from Assembly Bill 327 of 2021, which requires mental health providers and nurses to receive cultural competency training. So specifically, that's going to be psychiatrists, physician assistants serving under a psychiatrist, nurses, psychologists, social workers, marriage and family therapists, clinical professional counselors, and behavioral analysts. And they would have to receive, or they have to receive cultural competency training as part of their continuing education for renewing their license. So that That is the other requirement that currently exists in the law.
Thank you so much, Mr. Robbins. And I think that the standards and curriculum for those training programs have been developed or are in the development process and being negotiated with the higher ed institutions who would train in those areas. So Vice Chair Doñate, do you have any follow-up questions on that particular item before we go ahead and move on to our next agenda item? I believe that was a no, thank you. Okay, we're gonna go ahead and move on to our next agenda item.
Madam Chair.
Yes, please go
This is
ahead,
Gregory.
Assemblyman Hayden.
Thank you. I just had a follow-up to that. I have heard some concerns from the rural communities about the accessibility of the training. I think you just stated that the higher ed would kind of be involved. And so I just want to make sure that we're not adding an additional burden of days of travel. We're already understaffed in the rurals. And so I just want to make sure that there's going to be some accessibility to the rural communities for this training.
Thank you so much for bringing up that point, and I do believe that that's been considered, but I am not in the position of promulgating those regulations and developing those curriculums and process. So I can connect you or have staff connect you with the folks at Public and Behavioral Health who I believe are working on those regulations, but I do believe that options for virtual meetings are available. Dr. Titus, do you have any experience with this that you'd like to share, or we can just
I'll just add that I've asked that question many times, making sure through the healthcare that it's online. And even last time when we met, I was concerned about some of these regulations and access. And they assured me, I think with the speech pathologist regulations, I said, are you working on templates? And so I think much of this can be online. And so it's really up to the boards that are requiring this to make sure their members have it online as far as I'm concerned.
awesome. So it looks like a bunch of folks are on top of this. We have a member in the audience, I believe, Mr. Cafferata, who has a comment on this. We are not in public comment, but I don't know. Hold on, give me 1 minute recess.
Chair.
Mr. Cafferata, if you would like to come up and respond. I know you've been working in this space and working with a broad group on the topic area, so.
Madam Chair.
Dr. Hardy, can I come back to you post for this response, or do you have a comment that may integrate with this issue?
It may integrate.
Okay,
So
please go ahead.
I wanted to clarify, quote, it's in law, but until the regulations take place, are they not responsible for abiding by the regulation, therefore the law?
I'm going to let our legal staff answer that question. Mr. Robbins, please go ahead.
So with regard to the requirements for the cultural competency training of people in medical facilities, those requirements, they're in law, but they are in a regulation that has been adopted and is effective. So they do have to comply with those requirements.
I'm looking at the people in the rurals, for instance. Are they required? Is everybody required, or are we still waiting for regulations that have to be instituted in order for everybody who is affected by this law?
The regulations have been adopted, and so the requirements would apply to everyone, including rural areas.
Mr. Cafferata, do you have comments on this?
Good morning. Thank you for taking this exception. My name is Jay Cafferata for the record. I am currently a person who provides third-party training for NRS 449.103. The regulations were adopted and passed by the State Board of Health in 2020, and that training has been going on since that time. There are currently 4 providers that are available to anyone in the state to take that training, and that can be found on the Department of Health and Human Services HCQC website. including, as legal said, the ability and the avenue to apply for additional trainings to be approved. Under the NRS, not NRS, sorry, AB 327, those regulations are still being developed, and so that has not been completed at this time. However, the state licensing boards are the enforcement action of that, and so not the state. And so each licensing board has to approve their own set of regulations about how and what they will accept as meeting the terms of that law. For 449, though, that has been done and is already done. There are two providers for an online version of the cultural competency that meets NRS 449, and UNR and myself are the trainers for that. That has been available online since August of 2021. So it is available to anyone at any time, 24/7. And so it is available. There is a provider in Las Vegas that also has an online class. Currently, as part of our contract with the state, this training is provided to any state employee at no cost to them. So anyone from the state can take that training that meets the requirements of NRS 449 as well as 327, because in the law about 327, it says that NRS 449 will cover and meet the requirements for that. And in looking at the regulations that just were proposed for the psychological board, that also includes training that is approved for 449, will also meet their requirements. So all of these avenues have been sort of covered already, and that training is available and online. Thank you.
Thank you so much.
Madam Chair.
Please go ahead.
So I get a mixed message here. I hear the words, things are covered, but are they required by everybody, whether or not they're in a hospital setting before the regulation, or is the regulation still pending in some instances, and therefore they're not responsible for it until the regulation passes everywhere to everybody?
I'm going to ask our legal staff, Mr. Robbins, please respond.
So the regulation for medical facilities and facilities for the dependent under 449 has been adopted and approved. So the requirements for that, they're effective, they apply to everyone. So everyone who works in a medical facility or a facility for the dependent currently has to take this cultural competency training. The AB 327 requirements, as Mr. Cafaretta said, those are still being adopted by the various licensing boards. And so those are requirements for mental health providers to take cultural competency as part of their continuing education. And so those are not effective yet, and those people don't currently have to comply with them.
Thank you, Madam Chair.
This is Jay Cafaretta again. Can I add to that one little thing? Because some licensing boards have approved their regulations, like the State Board of Nursing has already approved their regulations. So those are in effect, and they went into effect on January 1st of this year.
Thank you so much. And Dr. Titus has another question or comment.
Just to follow up on that, thank you, sir, for some clarification there. You mentioned that it's free to any state employee. However, what about the rest of us that aren't state employees, that we are mandated to do this? And is there a waiting period? I mean, just have, so you can sign up online so that hopefully those in the rules can sign up online, but what would be the cost to the average person, that one of these professionals that has to get this done?
Thank you for the question. This is Jay Cafaretta again. So currently the training is 9 hours long. It is available asynchronously, so that's for anyone. The cost is $100, which is about $11 an hour for CEU. So
follow up on that, because I thought the law says we have that there has to be 2 hours of training and some of the regs.
So the other piece of that is that under 449, the facility must provide the cultural competency training and not the individual, because that's under the licensing statute and it has to do with the licensing of the facility. When you look at 327, those are by the different boards, and those requirements are by each board depending on whatever they decide. is going to be required. Both laws, well, no, 327 says a minimum of 2 hours. It doesn't add any length of time or how long it has to be, but it does have a set of topics that must be covered. And in 327, it adds 2 additional groups of people over the number of people that are under 449. And those are veterans and people with mental illness.
So you offer a 9-hour program. Do you have the Cliff version of that, a 2-hour program?
Absolutely not. It cannot be reduced in any way that I have found. None of the other providers also provide this in anything less than 9 hours. Just because of the level of rigor and depth that the law requires, there are certain criteria that are in the regulations that have to be met in order to become an approved course. And so it's not intended to just be a check the box. It's intended to actually change behavior. And so when we look at adult learning principles, we understand that you cannot be led to change your behavior in a 2-hour period and cover all of these topics. You can't even read the law in 2 hours and cover all the things that are under 449.
I appreciate the interest in this topic area. And I think, I think it's a little bit of a tangent for today, but very important. And especially in this area where we are understanding the really dynamic relationship that the healthcare industry has with our cultural and societally encouraged biases, and how do we break those down. So I appreciate the work you guys have been doing, and I appreciate the interest from our providers who are responsible for taking this training. As a side note, I don't work in the healthcare industry. I work with potentially hazardous materials, and I have to take a 40-hour initial training for hazardous material handling and an 8-hour training annually after that. So I don't think that this is too much for professional expectation for education, but appreciate the interest. And if you would like to continue this offline, I would encourage that. All right, we're going to go ahead. Thank you so much for your.
Madam Chair.
Yes,
I
Dr.
have major issues with the legislature saying 2 hours, and then we have a de facto, you have to take 9 hours. The things that you're talking about are for people who are already in the field. And if we are requiring 9 hours to get a certificate, as it were, instead of what the legislature has said to take 2 hours, then the person can obviously go, quote unquote, out of state to get some training. But I have a major problem when we start saying, oh, well, we're going to make something more than what the legislature said. I think that is irresponsible for what we're trying to say to our people when we require something, and then lo and behold, it is multiplied by 4 points something. I have problems with that. Thank you.
Thank you for the comment. We did, just for the record, say at a minimum of 2 hours in the legislation. So it does not exceed that to the extent of not being what our intention was. I'm going to go ahead and move on from this particular item. We can, if you have additional questions or comments, please feel free to reach out to Public and Behavioral Health HQC. Is it CQ? HCQC. Acronym central, you guys, and discuss with them the expectations for that training. Also, as we start to integrate more of the understanding of cultural competency just societally, we may need less training as people just inherently understand the needs of a diverse body of people, such as we have in the state of Nevada. Okay, we're going to move on to our next agenda item, which I believe is 7. Great. We're on item 7, rates of cannabis and illicit substance use during pregnancy and neonatal abstinence syndrome and the implications on child welfare. We have some folks from the state, it looks like, and some representatives from healthcare facilities here to talk about this particular issue. It looks like we might be just on time for Dr. Nagar. Perfect. I see some folks coming up. Please introduce yourself and begin when you're ready.
Hi, I'm Alexia Benshu from the Office of Analytics. Can you hear me?
We can't, thank you.
Okay, I'm going to share my screen. Okay, can you see my screen?
We can, thank you.
Great, thank you so much. Okay, good morning. My name is Alexia Benshuf. I am the Bureau Chief for the Office of Analytics, and I'm with the Department of Health and Human Services with the state of Nevada. Today, I'm going to be presenting on prenatal substance and marijuana cannabis use, neonatal abstinence syndrome, and child welfare impacts. To begin, I'd like to provide some background data on self-reported substance use in the general population. The National Survey of Drug Use and Health collects self-reported substance use from Americans aged 12 and older. And for a question asking respondents if they've used any substances within the last 30 days, in 2020, 13.5% of national respondents reported using illegal drugs, 11.8% reported using marijuana, and 1.9% reported misusing prescription drugs. In Nevada, the Behavioral Risk Factor Surveillance System collects self-reported substance use for citizens aged 18 and older. It asks a similar question to find out if respondents have used any substances within the last 30 days to feel good or get high. In 2020, in Nevada, according to the BRFSS, 2.9% of respondents reported using illegal drugs, which is lower than similar national data, and 19.4% of respondents reported using marijuana, which is higher than similar national data, and just 0.8% reported misusing prescription drugs. As you can see on the line chart, rates of self-reported marijuana use in the general population in Nevada via the BRFSS have increased since legalization in 2017. Data related to self-reported substance use during pregnancy is available from the Nevada Electronic Birth Registry System. And self-reported data from the birth record may be underreported because of stigma and legal implications. And so for context, out of 33,139 births in 2021, just 3% of mothers reported substance use. Before we get into the data slides, there are a few definitions I'd like you to be aware of. Select substances includes alcohol, heroin, marijuana, cannabis, methamphetamines, opioids excluding heroin, and polysubstance use. Whereas illicit substances include cocaine, heroin, methamphetamines, opioids, polysubstance use, and other unknown illicit drug use. And in this category, marijuana, cannabis is not included. Some prenatal substance use data are broken down by geographical region, which you'll see. I just want to point out that these regions match those of the Nevada Regional Behavioral Health Policy Board, which are Washoe, Northern, Rural, Southern, and Clark. And you can see that specific counties are included in various regions. And just want to point out that the Southern region does not include Clark County. Overall rates of self-reported prenatal substance use remain relatively stable over the last 10 years, except for marijuana and cannabis. You can see from 2017 to 2021, self-reported prenatal marijuana use increased by 212%. Now, when looking at illicit substance use by region, we can see over the last 10 years, for most of the last 10 years, Washoe County had the highest rate of self-reported illicit use. Most recently in 2021, they had a rate of 12.0 per 1,000 live births. And in 2021, Clark County had the lowest rate of 6.7 per 1,000 live births. And just a reminder that illicit substance use does not include self-reported marijuana or cannabis use. When looking at prenatal illicit substance use by race and ethnicity, we can see in most years that American Indian, Alaska Native non-Hispanic, white non-Hispanic, and Black non-Hispanic people had the highest rates of self-reported illicit prenatal substance use. Now moving over to prenatal marijuana use, we can see that rates of self-reported prenatal marijuana use have grown statewide since legalization. We can see in 2021 that the regions of Washoe, Southern, and Northern had higher rates of self-reported use, and Clark County had the lowest rate of self-reported use, but growth is seen across all regions in Nevada. Additionally, prenatal self-reported marijuana use is increasing across all age groups, especially since legalization, and we can see that rates continue to be highest among Nevadans aged 15 to 24. Prenatal self-reported marijuana use is also increasing across all race ethnicity groups since 2017, and most notably among American Indian, Alaska Native, non-Hispanics, and Black non-Hispanic Nevadans. In 2021, these groups had the highest rates of self-reported marijuana cannabis use.
Amen.
Prenatal substance use can result in neonatal abstinence syndrome, and neonatal abstinence syndrome is a group of issues that occur in newborns who are exposed to addictive, illegal, or prescription drugs while in the womb, and withdrawal or abstinence symptoms develop shortly after birth.
What does that look like?
The Centers for Disease Control and Prevention report that the number of babies born with neonatal abstinence syndrome is increasing nationally. Between 2010 and 2017, nationally it increased by 82%, and increases were seen for nearly all states and demographic groups. And comparatively, in Nevada, the number of babies born with NAS increased by 152% in that same time range.
I guess that's what
I'd like to briefly touch on the methodology we use in
Clark.
Nevada for identifying infants with NAS. We look at inpatient hospital billing data. Infants must be Nevada residents who are hospitalized within 1 year of birth, and they are associated with ICD-10 codes of P96.1 and P96.2, which relate to withdrawal symptoms in newborns. And our methodology is similar to that of the national data shared by the CDC previously. As noted, neonatal abstinence syndrome has increased in Nevada since 2010 and peaked in 2016. We can see from 2016 to 2021 that inpatient admissions for NAS decreased by 42% before increasing again recently in 2021. When looking at neonatal abstinence syndrome by race and ethnicity, historically, we can see that white non-Hispanics have had higher rates of NAS compared to other ethnicities. Although in 2021, American Indian, Alaska Native non-Hispanics had the highest rate at 10.9 per 1,000 live births, and white non-Hispanics had the second highest rate at 10.6 per 1,000 live births. Prenatal substance use and parental substance use in general do have an impact on child welfare. Substance use is a risk factor for child maltreatment, as it can affect a parent's ability to function as a caregiver and provide for their child's basic needs. In Nevada, healthcare providers involved in the delivery or care of substance-exposed infants must notify Child Protective Services agencies so that the need for intervention with the child and family can be assessed and a plan of care can be developed to ensure the safety and well-being of substance-exposed infants. In Nevada, substance-exposed infants are defined as children under age 12 months, identified as being affected by substance abuse, or who have withdrawal symptoms from prenatal exposure, or whose mother is receiving treatment for substance use disorder. And practices related to substance-exposed infants are guided by federal CARA regulations. CARA is the Comprehensive Addiction and Recovery Act of 2016, and it required states through CAPTA regulations to focus on the effects of substance use on infants, children, and families. So a CARA plan of care is something that must be developed when an infant has been identified by a healthcare provider as being a substance-exposed infant. And this plan, the purpose of this plan is to identify needs and services for the infant and family. The number of substance-exposed infants reported to CPS agencies in Nevada has increased from 2016 to 2021 by 80%, although the number of infants screened in for further CPS involvement decreased from 2018 to 2021, and this is likely due to changes in screening practices after CARA plan of care regulations were implemented in Nevada. Most infants screened in for a CPS investigation were determined to be safe with their family of origin. This is an average of 72% of infants between 2016 and 2021. This means that the CPS case can close and that further child welfare agency involvement is not necessary. We did see some changes after CARA regulations were implemented in Nevada. We saw some changes in the proportion of infants determined to be unsafe out of all infants screened into CPS, and this is likely due to those screening practice changes mentioned earlier. For the substance-exposed infants found to be unsafe during a CPS investigation, most had an out-of-home safety plan put in place while child welfare services continued with the family. And an out-of-home safety plan means that the infant is put in foster care. Foster care can be provided by relatives or fictive kin or by non-relative providers. And out of the unsafe infants with an out-of-home safety plan, the majority were placed in non-relative foster care between 2016 and 2021, although the proportion of infants placed with relatives or fictive kin over the years has been increasing. So this concludes my presentation, and I thank you for the opportunity to present, and I'm happy to take any questions you may have.
Thank you so much for the presentation. Are there any questions from the committee on this presentation today?
Yeah, how many Black kids are in foster care?
I
wanna know
see
that.
Assemblywoman Gorlow, please go ahead.
Thank you so much, Chair. I was just curious that besides the neonatal abstinence syndrome, do we have any other information on adverse birth outcomes such as preterm birth?
Alexia Benchoof, Office of Analytics for the record. Thank you for the question. We certainly can take a look and see what else we can provide on this topic for you.
Great, thank you very much.
Thank you.
Thank you so much. If you could provide that with staff, they can help disseminate that through the committee, throughout the committee. Thank you for the question, Assemblywoman. Are there any other questions on this particular presentation? We have a presentation from the provider coming up next who may be able to answer other questions as well. I see Assemblyman Hafen, please go ahead.
Thank you, Madam Chair, and I might have a couple of questions if you indulge me. My first question is, are we trying to do any education for upcoming mothers on the effects of marijuana use during pregnancy, mainly for preventative measures?
You stuck? No, you're moving.
Ms. Benchoof, are you available to answer that question? Do you have comments on that?
So Alexia Benchoof, Office of Analytics for the record. Again, this is something that we can consult with program staff and others in Health and Human Services, and we can get back to you.
Okay, and then my other question in that regards is, are there any warning labels on the marijuana products similar to tobacco and alcohol to warn people of the potential side effects of use during pregnancy?
I'm asking our legal staff to look at what we put in the law for recreational on what has to be included on those labels, because we may have included that on there. I think that our provider may also be interested in answering these questions as they would be more face forward with patients potentially. So I think if you want to hold on to those questions for our next presentation under this particular agenda item, that might be they may be able to help you with those questions.
Absolutely, and I just want to say thank you for the information, because this is kind of startling to see the 200% rise in this. So I just want to say thank you for bringing this to our attention.
Thank you so much. All right, I believe we have Dr. Nagar available from St. Rose Dominican to Dignity Health to present as the provider under this, but I'm not seeing. Oh, there she is. Hello. Please go ahead and introduce yourself and proceed when you're ready.
Good morning, everyone. Can everybody hear me?
We can.
Fabulous. And can you guys see my screen?
Did not see your screen.
Not yet.
We're stuck on the launching page.
Dr. Nagar, this is Kim with Broadcast. If you need some assistance, I'm here to help for you.
Wonderful. You know, I was seeing a challenge prior to presenting. So I've asked Andrea Peterson, who's presenting subsequently to me, to have it ready. Andrea, will you be able to get that pushed through?
Yeah, I can share my screen and pull it up now.
Wonderful.
Okay, just tell me when to.
Wonderful. Thank you so much. I love technology. I love to take care of babies, more importantly. So I'm very happy and very thankful for having this opportunity to talk about something that clearly is becoming a huge challenge in our community. I've been asked to talk about breastfeeding and cannabis use in the NICU, but yes, I'd be happy to talk about the NAS because that is a significant component of some of these challenges. As mentioned, my name is Deepa Nagar. I am the NICU Medical Director and the Chair of Pediatrics at St. Rose Sienna Hospital. It is a nonprofit hospital. I am a Corporate Director for Pediatrics Group, which provides services for the NICU care in the state, in every hospital in the state except for UMC. And recently we have started within our own group, a neonatal collaborative group, to look at how we can do a cohesive presentation of care across the state. And I am the chair for that committee. Next slide. So before presenting some of our data, I wanted to really first talk about what are the recommendations for the different committees that are out there, what are the different recommendations across the country. So from a CDC point of view, use of marijuana in any form, edibles, oils, etc., while breastfeeding can allow harmful chemicals to pass from the mother to the infant through breast milk or secondhand smoke exposure. To limit the potential risk to the infant, breastfeeding mothers should be advised not to use marijuana or products containing CBD in any form. These chemicals have the potential to affect a variety of neurodevelopmental processes in the infant. THC, which is the main component of marijuana, is stored in body fat. And unfortunately, breast milk has such a component of fat in it that there is a significant attachment of THC to the breast milk, and it is slowly released over an unknown period of time through the breast milk to the baby. CBD contains contaminants potentially like pesticides, heavy metals, bacteria, fungus, and can be dangerous both for the mom and the infant. Data on the effects of marijuana and CBD exposure to the infant, though, through breastfeeding are limited and unfortunately conflicting. And that's been one of our major challenges. Marijuana use may also impair a mother's or caregiver's judgment and ability to care for the infant. Next slide. FDA also has similar recommendations, but it really uses stronger words. Like FDA strongly advises that during pregnancy and while breastfeeding, mothers should avoid using CBD, THC, marijuana, or in any of these forms. The US Surgeon General says that marijuana used during pregnancy may affect the fetal brain. THC can enter the fetal brain through the mother's breast milk. This is during pregnancy, may increase the risk of newborn with low birth weight, may increase risk of premature birth and potential stillbirths. Breast milk can contain THC up to 6 days. That's recorded in FDA, but in other data, it says up to 6 weeks it can be present in the breast milk. And the newborn's brain development can be severely affected, hyperactivity, poor cognitive function, and other long-term consequences. Again, due to the inconsistent literature, this is one of the challenges that we are presented with the information. So other than the one approved prescription drug, CBD products have not been evaluated or approved by the FDA for use as drug products. This means FDA states if they do not know if they are safe and effective to treat a particular disease, what, if any, dosage may be considered safe, how they could interact with other drugs or foods, or whether they can be dangerous and have side effects that can have safety concerns. Next slide. Because of those statements through the CDC and FDA, ACOG, which is the American College of OB-GYNs, have similar concerns. They recommend that OB-GYN should counsel women against using marijuana while they are trying to get pregnant, during pregnancy, and while they're trying to breastfeed. And American Academy of pediatrics has also similar concerns about avoiding. Next slide. AAP says no amount of marijuana has been proven safe to use during pregnancy or while breastfeeding. During pregnancy, a lot of moms, when we anecdotally ask them, say they're using it for morning sickness. This has never been studied or determined to be safe. It is not safer than tobacco use. When smoked, the carbon monoxide in the blood concentration of these women is 5 times higher than when tobacco is used. This provides, unfortunately, less oxygen to the baby and may be one of the reasons for the smaller children and potentially preterm labor, but again, not clearly defined. And from a brain development problem side of the concerns, we have solving skills, memory, visual perception, behavior, attention, executive function, impulse control, especially as they're becoming teenagers. So these are all the concerns that AAP has stated as concerns about use of marijuana. Another concern is that THC concentrations in marijuana have actually quadrupled since the 1980s when the studies were initially conducted. So these concerns may actually be much higher, but we just do not have the studies. Next slide. Other studies have also shown some very significant concerns. In the women of childbearing age, marijuana use ranges between 15 to 28%. This is self-reporting. Unfortunately, in the United Kingdom, longitudinal development and infancy study that was performed across the United Kingdom found that most pregnant women who use cocaine, ecstasy, methamphetamines, and other stimulants and other illicit drugs usually stop using it by the second trimester. However, due to the potential lack of information and or beliefs, 48% of previous marijuana users continue to use marijuana as well as alcohol, which is 64%, and tobacco, 46%, throughout the entire pregnancy. And they have a very strong belief that it is less concerning than alcohol or even marijuana or even tobacco. So trying to change that belief has been a big challenge. Next slide. So what have we seen at St. Rose Sienna Hospital? We've looked at breastfeeding rates at time of discharge. One of the concerns that we've been working towards is trying to increase breastfeeding rates. However, we're noticing a significant drop. In 2020, maternal breastfeeding at time of discharge was approximately 55%. In 2021, it's actually a little bit higher at 58%. However, the ones who are not providing breast milk, when we are able to stratify the different patients, we see that approximately 23% of the babies who are not given breast milk are due to some type of drugs in mom's use of drugs during pregnancy and in the breast milk, which is significantly higher than 14% that we had in 2020. Of that, 60% have either just a marijuana exposure or a concomitant use of marijuana with the other substances. So the infant is exposed during the pregnancy with polysubstance use. I apologize, I don't have the 2020 numbers for THC use. However, we do know that it is higher than the 60% that I'm presenting in 2021. Next slide. So as a provider, I was asked to really talk about some cases, and I wanted to talk about just recent current patients that are in my NICU and how we are having some challenges. We know that breast milk is one of the best nutrition for babies. However, in the micro preemies and the preemies, we know that breast milk has some protective effects to the GI tract and to other organ systems. So from the literature, we have decided to provide exclusive breast milk diet to babies less than 34 weeks. This means that the hospital, with their own expense, pays for donor breast milk and supplementation like Prolacta and other calorie increasing options, for which are all breast milk related, so that these babies less than 34 weeks are getting an exclusive breast milk diet until their 34 weeks of gestation. We have had several babies who are born at around 33, 30, and almost 34 weeks gestation, where we are struggling to decide, should we start donor breast milk when in the next couple of days we'll have to switch over to formula. So we had this baby who was 33 and actually 37 weeks, and the mom had a history of marijuana use. She was adamant that she wanted breast milk diet for her child. When we presented her the information about the recommendations from AAP and the rest of the other federal government recommendations, she still felt that the breast milk diet would be best for her baby. And we made a compromise with her that she would pump and dump her breast milk for 1 week. And then we would check her breast milk to make sure that the THC was not in the breast milk anymore. Once it was safe, then we would provide that for her baby. Unfortunately, once the time came for her to be tested, she told us that she actually had not changed her use. And despite this use being for hyperemesis gravidarum, which is basically increased emesis during pregnancy, even though she'd had the baby and this was no longer a concern, she was not comfortable stopping her marijuana use. This did, of course, create a little bit of tension between the medical staff and the family, because she was so adamant that she wanted breast milk. We were able to convince her that we needed to use formula in this infant, and proceeded to care for this infant, which went home very well and healthy by approximately 35 weeks. However, we do know, and she mentioned that once the baby went home, she was going to breastfeed again. Another infant, this was a term infant who unfortunately, for other medical reasons, had perinatal stress and came out with APGARs of 0, 0, and 2, and subsequently went to need hypothermia, meaning this APGARs basically means this baby came out with no heart rate, no respiratory effort. We had to code this baby. Chest compressions were done, epinephrine was given. We were able to save this baby's life, and subsequently we placed the baby on hypothermia, which is a medically induced coma, and we cool them down to 33 degrees temperature to protect their brain and their organs for approximately 72 hours, so that we can decrease the chemical releases of in the brain and protect the brain. This baby had a wonderful outcome. MRI, EEG, everything showed that there was no effect from this initial perinatal stress. And even though this baby was born essentially dead, we were able to have a wonderful outcome. However, when it came time to start food, this mom also had a history of habitual marijuana use and was absolutely adamant that she wanted her breast milk given to our baby. Despite all of the education, including a neurology consult and subsequent education on the neurodevelopmental effects potentially from any of these exposure from either the THC or the cannabis and the contaminants that could be there, she was adamant that she wanted breast milk to be used. She called me and my staff, 4-letter words. They told us this was legal and it should be used. We tried to explain that alcohol is legal. That does not mean that it is appropriate for a baby, and the studies are concerning. She told us it was an organic product. When we tried to find out and have asked other moms we found that they're not getting them from the pharmacies, they're getting them from other sources. So despite trying to have education in other places, this mom again said, fine, we will use formula in the hospital, but once the baby comes home, I will be breastfeeding. Coming to a 24-week baby, as I mentioned earlier, there are significant components in breast milk that protect a very premature baby and help with their development, but also for their GI tract, which can absolutely become very ill. This specific process where parts or the whole GI tract can actually die. And this can lead to a child who is extremely premature, having to have multiple surgery, prolonged hospital stay, and subsequently other babies who may not even survive. And on the other hand, some of these babies end up going home on home TPN and need care for years because of a short gut syndrome. So when we have a 24-week baby, and same story, mom has a history of marijuana use. We showed her the significant impact on these babies with breast milk and how important her breast milk was. She decided that she would not provide breast milk because she could not stop marijuana use for her anxiety. This was not a prescribed medication. This was, again, off the streets, and she felt that that was more important than the numerous things that absolutely have been shown to benefit babies this premature. This is the end of the presentation. I'm happy to answer some questions regarding either this or opioids if you'd like.
Thank you for the presentation. Those are really intense examples. And I'm digesting. Anyways, I have a couple of questions in the queue. I'm going to start with Dr. Titus. Please go ahead with your question.
Thank you for the presentation. Thank you for the lives that you have saved and the continual engagement to help these very vulnerable population that we have. My questions revolve around formula and the donor breast milk programs that you have, wondering how accessible that is to your infants, what your supply looks like, and how well that serves you, and is there other options throughout the state? Because the next question I have is what your supply of formula look like in Southern Nevada right now. And we're seeing continual articles where there are empty shelves where it comes to formula. I'm just wondering what your situation is in Clark County. Thank you.
That's an excellent question. So let me start from the breast milk diet component. So exclusive breast milk diet definitely has impact on the outcomes of these infants, as I mentioned, in multiple organs, but especially the neurodevelopmental and the GI tract, which is known to be a component of our immune system, and also has the connection between the gut and the brain health. So we believe very strongly in the improvement in outcomes due to breast milk. Because of that, Dignity Health specifically has for over a decade been providing at our own cost breast milk from a California breast milk bank. Thank you. Sorry about that. A breast milk bank that we provided, and then we are providing the extra calories use of Prolacta, which is 10 times more costly than formula. This is again provided from our own cost. Because of the increased cost, not every hospital in the state provides an exclusive breast milk diet. We know that the HCA has use of donor breast milk, and they are going to be bringing Prolacta soon. The Valley Systems does not, and the Reno system does have donor breast milk. All of that is, of course, provided by the hospital and their cost. There are some challenges to overall breast milk, donor breast milk from different state entities, and limitations are there because of this higher use of marijuana and risk of transmission of viruses. So the testing process for breast milk is actually more impressive than even blood products. So we are very, very careful about the products that we get. From a formula point of view, we are seeing challenges in the supply chain. We are able to make substitutions between the different formula companies and have the support of that. And recently, I was told today that there was an approval for Similac to open up their facility again, but there will be a probable 2-week delay before that that warehouse is up and ready for doing producing more formulas. For that reason, we have tried to educate parents about formulas from the different stores, that they are just as good as any name brands. We know parents are ordering supplies from Canada and other countries. That is a concern. And unfortunately, there's also some challenges happening where there's sharing of breast milk with strangers. And that is a very high risk because of transmission of viruses, drugs, and potential dilution of the breast milk, which can cause seizures and other complications in babies. So we are recommending to parents that they not share. And we are trying very hard to help support this lactation process without making the parents feel inadequate if they're not able to provide that breast milk. Did I answer all your questions?
Follow. Okay. So, and thank you for that. The great information. I'm just curious if there's, is Dignity Health or the Clark County Health Department or the state folks doing any public service announcements regarding the formula concerns and, you know, the risk of sharing breast milk and those kind of issues at all? Have you seen anything that our state is doing?
Not the state itself, but I have been asked personally to talk with several news outlets to be able to talk about some of these concerns. But it would be helpful if we had a cohesive message. One thing I do want to emphasize, because of these concerns, but also because marijuana is becoming so ubiquitous in the use across the country, more and more physicians are leaning towards the benefits of breast milk outweighing the risks that are potential and not well studied in some of these studies, and using breast milk in their units and with the babies. Because the formula concern is there, that is becoming even more of a concern in the hospitals, despite CDC, FDA, AAP, ACOG, all having statements like this. There are more and more units across the country and even in our own state, because of multitude of reasons, that now physicians are saying, if we don't have formula, or if mom is very focused on providing breast milk, as long as she's educated that there are risks, they're providing breast milk.
Thank you for that, and certainly concerned, but what I'd like to see, maybe, Madam Chair, hopefully our folks are on board, and I think this is something regarding the breast formula that we shouldn't take lightly, and I'm thankful that you're willing to do it, and the news media has reached out to you for some information, but I think our state is something we should get on board sooner than later regarding this formula issue that we have seen statewide. I think it's a true crisis that's not really being acknowledged. Thank you.
Thank you for your questions and comments. Are there any other committee members who have questions? Assemblyman Hafen, would you like to come back around to your question regarding labeling?
I can, and I also have an additional question, if I may, Madam Chair.
I have, I asked our legal counsel to look at the regulations regarding labeling, and he has an update for you real quick before we go back to Dr. Nagra.
Thank you.
Hi, Eric Robbins, LCB Legal. So the labeling requirements are spelled out in NRS 678-520, and currently cannabis products do have to have a label that says keep out of reach of children. In addition, a cannabis facility is required to convey to each purchaser of a cannabis product in the manner prescribed by the Cannabis Compliance Board, that cannabis should be kept out of reach of children. The cannabis product can cause severe illness in children, that allowing children to ingest cannabis or cannabis products or storing cannabis or cannabis products in a location accessible to children may result in an investigation by a child welfare agency, and also that pregnant women should consult with a physician before ingesting cannabis or cannabis products. And so this was actually changed last session. Previously, before last session, and it's a Senate Bill 168 that changed this. But before Senate Bill 168 from last session, the cannabis facility was required to include a written notification of these things with each sale, and now they have to convey this information to each purchaser in the manner prescribed by the Cannabis Compliance Board. I have not been able to locate any regulations proposed or adopted by the Cannabis Compliance Board to carry out the requirements of this regulation yet. So the regulations don't yet prescribe the manner in which this information must be provided by the cannabis sales facility. And if you have additional questions about that, I would recommend contacting the Cannabis Compliance Board.
Thank you so much, Mr.
I would just add,
please go ahead.
if I may just add to that. So when we anecdotally ask the moms about this cannabis use, majority of them will state that they do not go to any of these dispensaries. It's too expensive, and therefore they have not been educated on it. When we also did a QI study where we asked moms if anybody had educated them during their pregnancy, including their OB-GYNs, regarding the risk of marijuana use. And more than 75% of them said that they had never been educated, asked, or even told about the challenges of cannabis use.
Thank you. Assemblyman Haven, did you have a follow-up?
I do. Thank you for that information. I wish we could find a way to get that information out better. As I believe Dr. Titus stated, one of the things that you mentioned in your slideshow is that marijuana use should not be used when trying to get pregnant or breastfeeding, and that was specifically towards women. Are there any consequences or recommendations on the male side of this?
Unfortunately, I would not be an expert on that information since I focus on the babies, but I'm happy to research it and provide you that information if I can.
Thank you.
Thank you for the question. I had a follow-up question regarding research. Dr. Nagar, can you talk a little bit about who or what studies may be occurring around the use of marijuana during conception and pregnancy and the implications of marijuana in breast milk? Are there studies being done? I know it's very difficult to conduct studies on pregnant people because you never want to put the potential child at risk. But what is going on in that space?
Unfortunately, that process is very limited, and as you mentioned, the ethical implications of some of these studies have really limited that part of the studies. What we are doing is looking at the infants in the NICUs. As I mentioned, pediatrics does cover majority of the units in the state, but we also are providers for NICU coverage across the country, and over 30% of the NICUs that are private NICUs across the country, separate from the academic. So we have a very robust database of over 30 million patient days. And we have been following the increase in marijuana use and exposure to the infants. That is still in the process of being evaluated, and we're hoping to present that as a study. But obviously, the important part I want to emphasize is by the time they come to us, those babies have already been exposed, and we can only see the potential implications in the NICU and may not be able to do the developmental process because once the babies leave, they may not be part of our system anymore. So those challenges are very concerning because there are very limited focus on this kind of studies right now.
Thank you so much for that. Are there any other questions from the committee? I have additional questions, but I will ask them offline because we do have quite the agenda to get through. So I'm not seeing any other questions. Thank you so much, Dr. Nagar. I really appreciate you being here today. And we will go ahead and close this agenda item.
Thank you.
Next, we are going to move on to agenda item 8. This is an overview of programs to treat substance use during and after pregnancy. I have Dr. Peterson with Empowered, I believe, who, please go ahead and introduce yourself and begin when you're ready.
Madam Chair and members of the committee, for the record, my name is Andrea Peterson, and I am Executive Director of the Empowered program with Roseman University. Thank you for having me here today to present an update on Empowered, and also just want to say that I'm grateful to be able to follow Dr. Nagar. I had the privilege of working with her for 12 years in that NICU that she was talking about, and we were great colleagues. So she's also the co-founder of the Empowered program, so I would like to acknowledge that as well. So those of you that don't or are not familiar with Roseman University, I wanted to provide just a brief amount of information. We were founded in 1999 in Henderson, Nevada. It is a nonprofit private institution of higher learning that is focused on the health professions. We do have a College of Medicine, College of Dental Medicine, College of Pharmacy, Nursing, and Graduate Studies. We have campuses that are established in Henderson, Nevada, Las Vegas, Nevada, and the Summerlin area, and then also in South Jordan, Utah, and we are regionally accredited by the Northwest Commission on Colleges and Universities. And I will say I'm a product of Roseman. I attended pharmacy school there and graduated from there in 2008. So at Roseman, when we are in the classroom, we do something called active learning. And so I want to do something with you today that's an active learning. And so I want you to look at these pictures. And I want you to look at what you think these moms and babies have in common. And for those of you that know me, I know there's a couple who've known me for several years, you might know where I'm going with this, but I want you to really look at the faces of these moms and these adorable babies. This one's focused more on the babies. And here's some group pictures you can see. So, you know, as you look at these women, you're going to see women that might look like your sister, your friend, a coworker. When you go to the grocery store today, you might, see one of these faces. So to let you know what they have in common, they're all program participants of the Empowered program. And the Empowered program supports pregnant and postpartum women with substance use disorder. And so all of these women are in various stages of recovery. Some are still currently experiencing substance use disorder and navigating that. And all these infants that you've seen today, when they were born, were at risk for neonatal absence syndrome. So I think it's really important to be able to put faces, to the information that we're talking about today when we talk about substance use disorder and pregnancy and neonatal absence syndrome and what it looks like. It looks like these women, and substance use disorder does not have a face. I wanted to touch briefly on some Nevada trends, and we've had some great data today. This came from the Overdose Data to Action grant that is through the state. And this is specifically suspected drug overdose related ED visits from January of 2018 to November of 2021. And the reason I wanted to point this out is because everybody's always curious about, what did COVID do? We know that COVID impacted mental health. We know it impacted substance use disorder. What did it do? The data that you're looking at is specific to Nevada and is specific to women of childbearing age. And that was defined as ages to 15 to 49. So I think a lot of times people think, oh, women of childbearing age, maybe women in their 20s, it's 15 to 49 here. And so this is a large percentage of our population. And so what you can see in this March 2020 COVID is that spike. And you really can see that it's remained elevated. And again, these are suspected drug overdose related ED visits. Moving on to look at another Nevada trend, this is the annual rate of suspected all drug related overdose ED visits, again from January of 2018 to November 21, that is specific for that women of childbearing age. And so you can see that percent change from 2018 to 2019 is actually negative 4.6%. And then 2019 to 2020 jumped 9.5%. So again, you can see the impact on the specific population with overdoses. And to kind of cap it off, there was some data that was released by this team. Again, it was just last week. So if you haven't read that report, I really encourage you to look at it. But what they found is that there was a 20% increase in the rate of accidental drug overdose deaths among Nevadans from January 2020 to June of 2021. Just to pull out a couple of other interesting things that they noted, 65% involved in opioid, 58% involved in stimulants. So those are that you might not be familiar, that's likely going to be methamphetamine. 1 in 3 involved in opioid and a stimulant. So that's what we'll frequently refer to as polysubstance use, more than one substance. 3 in 4 overdoses occurred in the home, and 1 in 3 had a mental health diagnosis. So essentially, everybody's done such a great job today of talking about this, but the problem is that drug-induced deaths are the leading cause of death for reproductive age women in the US. It's higher than motor vehicle accidents, gun violence, homicide, is drug-induced deaths. So we know that this plays a huge role nationally. We know that this is playing a huge role locally in Nevada as well. The effect of this is that infants who are born to these mothers are going to be at risk for neonatal absence syndrome. So essentially that's withdrawal symptoms that are seen in infants born to mothers who've used drugs during pregnancy. And just to give you an idea, a large percentage of these births are funded by Medicaid. It's reported to be 82%. When we looked specifically at the Empowered program, we found that 90% of our moms did have Medicaid. So how do we identify someone with a substance use disorder? We saw those pictures, we saw those moms. Again, I don't think any of us would look at them in line, at the grocery store and identify that they have a substance use disorder. So that's going to occur through a process known as SBIRT. It's an evidence-based process, and it identifies individuals with a substance use disorder and those who are at risk for a substance use disorder. It is actually an acronym, so it stands for screening, brief intervention, and referral to treatment. And I wanted to take a minute to thank this committee because I had the opportunity to be able to work with the committee to pass AB 442 this last legislative session, which does require all providers in Nevada to obtain 2 hours of CE credit in SBIRT one time. So just really, really grateful and excited that we can promote this evidence-based practice throughout all of our providers in Nevada and make sure that they are practicing it appropriately. And just to let you know, SBIRT is a billable process. So what do we do once we've identified someone with a substance use disorder? That's always the question, right? If we screen, then what do we do? And so I want to talk specifically about the Empowered program, which is a referral source specific to pregnant and postpartum women in Southern Nevada. The program originated in Dignity Health, and it was there from June of 2018 to July of 2021. And essentially what we did is we created a care coordination program that linked pregnant and postpartum women to services within the community. Because what we found is that services are available. It's just very difficult and overwhelming for women to be able to navigate these services. So we helped provide linkage to care for prenatal care, medication-assisted treatment, housing, employment, support services like baby basics, maternity items, baby parenting classes, etc. We had a lot of success. We had 275 patient encounters during that time, and I won't go through each of these statistics, but you can see 42% did receive referrals for medication-assisted treatment, 44% for prenatal care. We assisted with transportation, 84%, and what we found is that when we assist with that transportation, we have high rates of recovery and women do well. 26% needed assistance with housing. And we also learned a lot through that process, and we made some observations. So with regards to overdose deaths, women of childbearing age continue to be at a very high risk of developing substance use disorder. Screening by all healthcare providers is absolutely imperative. And I want to just highlight that it's not just women, it's not just individuals of childbearing age. This should be everyone. Everyone that is seeing a provider should be screened for substance use disorder. We also noted that patients with substance use disorder need strong support networks. They need strong home visiting programs. They need wraparound services for the entire family to fully support mom and baby. And I just want to remind you, kind of back to that data that I presented in the beginning, 3 in 4 overdoses in Nevadans occurred in the home. So that family unit in that home is very important. So our solution to this was the Empowered program at Roseman University of Health Sciences. We were able to work with Dignity Health to move the program to Roseman, and we've been able to expand services. So we're able to support that mom during pregnancy and that postpartum period. We support them with peer recovery, advocacy, specific treatment and resource provision designed around their need. It's very patient-centered and person-centered because none of us have the same needs. And when we meet with them, we identify what is their most urgent need for their recovery. We help with community support, and then we facilitate a referral to Genesis. And Genesis is a household-centered home visitation program that is focused on the social determinants of health. And so this involves a team actually going into the household, surveying the social determinants of health that are impacting recovery, and helps that family navigate those. Our mission statement is that we develop and unleash the power of expectant and recent mothers with opioid and stimulant use disorders to be active in managing their health and partnering in their care. And this really is my favorite part because it's from recovery through stabilization to resilience, because we really want to promote that resilience piece. And I'm so excited to share that we have women who are getting jobs. We have somebody graduating high school this week. We're having such great outcomes because we don't want to just have them survive. We want them to be able to thrive. This again is accomplished through iterative assessments, personalized patient-centered care plans. We have counseling services, including individual and group therapy when needed, health education, and then of course the facilitation of those referrals and care coordination. It's just a picture of what our patient journey looks like. So once we have enrollment, we do that comprehensive assessment. I just want to note here that many of our program participants do present in crisis. So whether if they've just delivered, sometimes they lost a child, or they had them separated with the Department of Family Services. Sometimes they're worried about that. So we help support them in that crisis. We stabilize them through that crisis, and then again, develop that individualized patient-centered treatment plan. We manage those interventions, provide case management, and continue to follow them through pregnancy and that postpartum period. Our goal is then to leverage the capacity and strategic processes of Roseman to deliver enhanced services. So again, we're now able to offer that individual therapy and that household-centered home visitation program. We provide access to care, support, and advocacy for participants, add those educational and counseling services with individual and group therapy. We manage the social determinants of health of program participants and their families, and we support them from their recovery through stabilization to resilience. And just to kind of show you what this looks like, we had a patient case this week who has been involved in our program. She's lived in Nevada for more than a year. She's separated from her child, and she has no ID. And to be able to engage in a lot of services, you have to have a government issued ID. And so we've been helping her with that process. And just this week, we were able to provide her with transportation. We paid the fee for her ID, and she was able to go to the DMV with our care and was able to leave the DMV with a government issued ID. And she called our care manager afterwards and just said, "This is life-changing for me." So it's just so humbling to think, everyone again is just in various stages of their recovery. Everybody has different things that are impacting them to be able to make a successful recovery. And sometimes it's as simple as an ID, and we're able to help provide that. I wanted to briefly touch on some barriers to treating substance use disorder in Nevada. One being that collaborative care codes are not covered by Medicaid. A second is that behavioral health is not included as a chronic health condition addressed by community health workers. So I believe earlier today there was a presentation on that, and it's so wonderful now that we're able to have community health workers as a reimbursable program in Nevada, but behavioral health is not included in that. And then peer support services are not reimbursed in healthcare settings. And I just really want to emphasize the importance of those community health workers and peer support in treating substance use disorder. The last thing that I wanted to point out is access to buprenorphine. So those of you that aren't familiar with the medications that are available to treat opioid use disorder, there's methadone, which probably a lot of people are familiar with. There's also buprenorphine, among others. But buprenorphine is a life-saving medication that is used in medication-assisted treatment. I want to specifically point out that neonates who are exposed to buprenorphine in utero have significantly lower rates of NAS and shorter NICU stays compared to methadone. And I know that Dr. Nagar would agree with me when I say that for the most part, infants who were admitted to our NICU who were exposed to buprenorphine in utero did not experience NAS. They did not experience withdrawal. Health and Human Services recognize the importance of this medication. They recently expanded access to buprenorphine, so they revised their practice guidelines to allow practitioners to treat up to 30 patients without having to obtain certain training-related certifications. So it was great. One of the barriers that we're seeing is with regulation NAC 639.748, and that's where it requires a current and valid form of ID issued by a federal, state, or local government agency that contains a photograph. And so again, just many of the program participants that we have are lacking this government issued ID, and it takes time to be able to get that ID. And it's really important that when somebody wants to engage in treatment and they want to be able to make a change, it's really important to be able to support them with that in the moment and not to have it bogged down by that ID. And so with them lacking this ID, oftentimes when they're able to go and get a prescription for buprenorphine, they're not able to pick their pharmacy or their medication up from a pharmacy. So just wanted to bring awareness to this issue. Some of you may be familiar, there's a Clarity card, which is a homeless ID that is not recommended or not recognized at this time as a government issued ID. So it's very easy to be able to get that homeless ID or that Clarity card, but very difficult to get a government issued ID. And I will open it up for questions.
Thank you so much for the presentation. Are there questions from the committee on this presentation? I cannot see you, so please unmute yourself when you are ready to ask a question. I am not hearing any questions at the moment, but I have a question about what we're doing around stigmas that exist for birthing people who use drugs, and how are they offered care and treatment. You discussed some of that, but I'm just wondering if you can talk about some of the efforts to reduce bias and stigma in within the treated populations, but also within the treatment system.
That's a great question. And something for the record, this is Andrea Peterson. I'm not familiar with specific efforts around stigma. I know that we've had this with a group that I participate at the state level, that's the Nevada Reproductive Health Network, that this is something that is needed. Really what I'm familiar with is that SBIRT, which is going to be around screening, which is that screening, brief intervention, referral to treatment. It is evidence-based and does provide guidance around how to have those conversations.
Hi, this is Dr. Nagar. Just to add to that, the screening process for the SBIRT is universal, and that is one of the importance of not having biases with certain populations and only asking questions in those populations. So the recommendation absolutely is to be universal in these questions and seeing what at risk for patients are present. The second thing I wanted to just emphasize, after hearing these presentations across the board, what I hope you guys are seeing is the impact of the support during pregnancy can absolutely impact the life of that mom and the baby. And because of that, having a cohesive plan for the state that looks at the perinatal quality collaborative is one of the key components to make sure that we as a medical community and as a state are looking at the care in a continuum instead of just having silos, realizing that there are issues, but not having that continuity in place. We have absolutely seen an improvement in outcomes, as Dr. Peterson mentioned about the decrease in opioid withdrawal in these infants with buprenorphine exposure, but we've seen it even with these moms getting treatments in the medical assisted treatment facilities. They're no longer on polysubstance use, and therefore the baby is not exposed to multiple substances. Their process of withdrawal is significantly improved because moms have shown that they are getting this care during pregnancy. They have followed appropriately. They know we can now say, yes, that baby and mom together are safe pathway instead of separating the mom and baby. We can work on breastfeeding with them, which again improves not only the connection between the mom and baby, but we know that these women are more likely to not fall off the wagon. They actually are more likely to continue being in their sobriety. So there are so many components that are absolutely essential if we can look at the continuum of care and work as a community from pregnancy to delivery. And we know that 1 year postpartum, the risk of overdoses are actually highest after the first, I think it's 8 months. That's when the risk is the highest. So that's one of the reasons why having that Medicaid coverage up to a year is so critical.
Thank you so much. I appreciate your perspective in that point. I also want to take a moment to just highlight the statistics around transportation and the increased success of treatment. And I think that this is kind of across the line when folks have, when barriers are removed from accessing care, people are more likely to seek treatment and to complete treatments. And this isn't just for behavioral health, we also see it for physical health, but it's so much easier, I think, sometimes to dismiss or diminish the need for continuous mental and behavioral health care, that those barriers are still so problematic. So I appreciate the statistics, and I look forward to bringing those forward and talking more about what we can do as a state around public transportation to ensure that that barrier is diminished for most people in our state. Are there any other questions folks have on this presentation? Committee?
For the record, this is Andrea Peterson, and I would just say that that's really where the social determinants of health come in. It is essential to be able to identify the social determinants of health, in those underserved populations and those at-risk populations, to be able to identify their barriers to accessing care. Because you're right, when you remove them, they do engage in care and treatment and have really great, successful outcomes.
Thank you so much, Dr. Peterson. I do not see any other questions or comments from committee members, so we're going to go ahead and close this item and move on to our next. Thank you again so much for the presentation and for being here today. Our next agenda item is agenda item 9, the need for a Nevada perinatal quality collaborative or a professional network to enhance the quality of care for mothers and babies and other considerations to improve obstetric outcomes. I'm very excited for this presentation. I think one of the things as a mom of 3 kids that I would love to see more of is really the overlapping of care and services and making sure that we're looking holistically at family health metrics and not isolated maternal and baby health metrics. I think we're moving towards that, but I'm looking forward to this update on where we are and what we can do to help. So please proceed and introduce yourself when you're ready.
Can you guys hear me? This is Dr. Rainieri.
We can, thank you.
Great. Well, I'd like to thank everybody for welcoming me back. I spoke before you in January of 2020. And I also like to thank Dr. Peterson, Dr. Nagar for being my straight persons for me in many of the things I'm going to be presenting here today. I'm the president of Hera Women's Health, which is a national healthcare organization. I'm also the managing physician as a subspecialist in maternal fetal medicine at the High Risk Pregnancy Center, and we have offices in Vegas, Henderson, and Reno. My background is I was the former president of the Society for Maternal Fetal Medicine, which is the world's most recognized high-risk pregnancy organization. I'm the current president of Hera Women's Health, as I talked about, which is a national integrated healthcare model of multiple specialties. I've led 2 national workshops put together by ACOG and Society of Maternal Fetal Medicine and NICHD for quality measures in obstetrics and also implementation science. I've written over 25 research articles, and I currently serve as the primary investigator for the PRIME trial, which is the largest preterm birth study in the US in the last 2 decades. The last time I was here was in January 2020. It was quite a different time then. I presented several things moving forward about the support for perinatal collaborative, change in the poverty threshold for Medicaid coverage for pregnancy, to provide 1 year postpartum coverage, which we're still trying to get to support different types of payments for behavioral health in offices, and to support payment systems to screen for medication-assisted treatment. We were successful on some of these things, but not on others. And part of the reason why probably was right after January 2020, we kind of fell into the coronavirus issues that came on in our society. So I'd like to bring forward a little bit of this data that we talked about in the past, and then move forward to why it's so important to move forward in the future now that we're coming out on the other end of the coronavirus epidemic or pandemic. Within the United States, our maternal mortality ratio is one of the highest in the world. I think it's like 57 or 58 now, and we're last in developed countries. As you can see, the maternal mortality rate is the death of a pregnant woman within 48 days of the termination of pregnancy or 6 weeks postpartum, and it's expressed over 100,000 people or 100,000 births. The U.S. had the highest rate at 17.4. Other countries, as you can see, are much lower. The issues of this are not just expressed overall, but are, as in many health conditions, felt in a disparate fashion, with Black populations having 3 times the maternal mortality rate in comparison to Hispanic populations and 2.9 times greater than that of Caucasian populations. CDC thinks that this is mainly due to variations in healthcare, pre-existing underlying conditions that are maybe exacerbated from inability to gain access, and then also structural racism and implicit bias. Within Nevada itself, we've been seeing us for the blue bars here. We've seen an uptick in our perinatal or our maternal mortality rate. This, I think, is partially due to how they've been counted, but as you can see, there's been a rapid uptick, and Nevada is kind of shadowing what the rest of the country is doing right now. When you look at it, you can actually see this increase from 2016 to 17. This is a different graph on pregnancy-related mortality rate. Pregnancy-related mortality rate is not 6 weeks postpartum, but up to a year postpartum from any cause related to or aggravated by the pregnancy. As you can see, we're kind of stable from 2012 to 16, but started seeing this dramatic uptick in 2017. The issues, though, again, are really highlighted further by the disparate nature of how this affects our populations. The Black non-Hispanic population, their perinatal related mortality rate is 63, Asian population is 55.8, white non-Hispanic 18.4. In the states that take their data and show it by race, our Black non-Hispanic perinatal related mortality rate is the highest in the country right now. And although I've been focusing a little bit here on maternal mortality rate, I really think the unknown story of this is the severe maternal morbidity rate, and not only the medical health of this, but the cost of this. Severe maternal mortality is thought to be 60 times greater than that of, or maternal morbidity is thought to be 60 times greater than that of mortality, and there's dramatically increased cost from that. The care of a birth that has severe maternal mortality is about 40% more than the cost of a birth without severe maternal mortality. And so where do we go from this? I think one of the clear answers here is a perinatal quality collaborative. The CDC thinks that, and I think the data does show this as well from maternal mortality review committees, that up to about 60% of all maternal deaths are preventable. And that would probably also lead to, maybe as high as a 60-fold decrease as well in the maternal morbidity rates. We really need a collaborative to increase our quality, improve outcomes, and decrease cost. We can't have multiple people reinventing the same wheel over and over again. We need a coordinated statewide team to be able to improve the quality of care for these pregnancies, use data-driven research, funded processes to improve our care and utilize these methods to make change. We're one of 6 states in the whole country without a perinatal quality collaborative beyond the development stage. The other 44 states already have a collaborative, and we're one of only 2 states in the country now that don't even have a developmental stage perinatal quality collaborative, us in Idaho at the present time. We're at a point right now where I think waiting for a grant is probably not a tenable solution. We did that with the maternal mortality review committees and weren't able to move forward until we received a grant. And this really put us behind and hurt our process for women in the state. and we're trying to dig out of that right now. Perinatal quality collaboratives really work. If you look at them, one of the initial examples of success for perinatal quality collaborative was the California collaborative. And if you look at the red bars, that's the increasing maternal mortality rate in the country. And if you look at the perinatal quality collaborative for California, went into place, I believe, in around 2007, and you can see the dramatic driving down of maternal mortality rates within California. They didn't also just decrease the maternal mortality, though. They decreased the maternal morbidity by 21%. They decreased collective deliveries, which lead to increased NICU problems by 55%. And the Illinois Perinatal Quality Collaborative decreased the time to treatment for severe hypertension, which is recommended in the US anywhere from between 30 and 60 minutes. That also decreases maternal death, and they showed in their study it decreased severe maternal morbidity and hence has a major cost savings. I think this is the best time to basically move forward with a perinatal quality collaborative, and the reason is all the hospitals are now going to be watched a little bit more. The CMS has adopted 2 maternal morbidity structural measures that need to be reported. Does your hospital participate in a statewide or national PQC? And has your hospital implemented safety practices or bundles related to certain conditions during pregnancy? Hence, we're kind of late to the game now with our formation because we're one of only 2 that really doesn't have one, and one of 6 overall. But it's going to be a question asked by CMS, and I think this is going to further drive hospital participation. When I came here in 2020, we were one of only 14 states without a perinatal quality collaborative. Now, as I said, we're one of only 2 states, and one of only 6 states either within the progress of forming one or don't have one at all. We're really in the don't have one at all game right now. What does it take to form a PQC? You need a director, website with video capability, data capability. I believe you do have REDCap now in the state. This was my older slide from the last time I was here. You need a meeting capability, travel, training, education, and marketing. How do you do this? You need some initial government funding, maybe some grants, maybe some user fees, which I'll get to in the next slide, and then go from there. But how much money do you need? Again, from the CDC, they recommend that these are the different levels that you're going to have. If you wanted a limited collaborative, anywhere from 10 to 100, moderate 100 to 500, substantial funding greater than 500,000. These are numbers from 2016. I believe Nevada would need probably 250 to 300,000 per year for 2 years, and then run based upon user fees possibly for this. I think if you did a smaller collaborative at 100 to 200,000 a year, we could probably get by, but not get ourselves up to speed like the rest of the country. I think you can also later incentivize perinatal quality collaborative work by linking pay for deliveries to hospitals, giving a plus 2% possibly fee for delivery for participating in a collaborative, possibly disincentivize non-participating hospitals by decreasing pay by about 5%. Require modules of participation for physicians. So physicians participate in this and all providers participate in this, and they get disincentives or payments or minuses in payments when they don't participate in the collaboratives. Or you could just fund this later by fees to overall hospitals, overall that are not related to payment systems. I think this really needs to be done and really needs to be done now. Maternal mortality and morbidity is, as I said, 60% of the cases are preventable. We really have a dramatically high healthcare inequities issue, the highest in the country, and who's reporting it right now for our Black populations. And putting something like this into place saves money as well. If you decrease early deliveries, you decrease subsequent NICU care, and you also decrease the cost of severe maternal morbidity cases. I think we need to concentrate our efforts on improving care to prevent these unneeded or preventable catastrophes and really reduce costs of neonatal care. I really want to emphasize that spending on pregnancy care is probably the most preventative care that you can do, because you're taking care of 2 patients at once and you're altering the lifetime trajectory for a younger baby throughout its lifetime spectrum. Pregnancy is really the ultimate value-based care. And that kind of adds or ends where I want to go forward with a collaborative, and hopefully that convinces you. But also we have some other issues that I want you to look at. And if you see the spending in pregnancy, I'll be able to kind of maybe put it together for you in a way that is more understandable. Within the US, about 42.6% of births are covered by Medicaid. Pregnancy itself, though, is not in the 20 most expensive costs in the United States. The care of the newborn is the third most expensive condition treated in the United States. We really need to spend on pregnancy to decrease costs in care of the newborn. Next, people think physician fees are things that are problematic. Physician fees have only increased over the last 15 to 20 years, maximally by COLA increases, and many times not even by COLA increases alone. Almost all the increases in cost now to the system are dominated by hospital increases in costs, almost doubling in hospital increases in costs overall. US spending on obstetrical health, if you look at it by the billions, hospital fees are in the brown here are about 52 billion a year in the United States. OB provider fees are about 18 billion per year in the US. NICU fees, which only treat about 10% of the patients being treated, or 10% of the pregnancies, is also 18 billion. It's equal to the entire amount of OB provider fees overall. OB anesthesia, which takes care of a pregnancy for several hours during delivery, is 7 billion around the United States in comparison to the 9 months of the delivery spent with obstetrical fees. And this is a big problem in Nevada. I mean, we have overall, if you looked at this study, it was from last year, we have the highest OBGYN shortage in Las Vegas in the whole country. This leads to people running to different hospitals, not being able to spend as much time on the care that they need to on patients because they're busy and they're basically understaffed and can't have the ability to deliver as high a quality care that we want them to. So I would ask that we need some increases in payments to providers to decrease this undersupply. Global payment increases are kind of needed urgently. At the same time, I think the physicians should be responsible for payments. If we're going to increase payments, we should make payments for value and for true quality care. We should encourage our payers to develop systems to decrease neonatal intensive care unit stays. And we should disincentivize providers that don't follow care standards by giving disincentive payments to them to offset their global payments. And then I don't like solely recommending changes in payment on outcomes. I think in doing that, it's penny wise and pound foolish. In those instances, what you get is you get providers that will then cherry pick patients that have less problems. And if you do that, you'll probably exacerbate disparities, maternal morbidity, and also mortality. And then one interesting payment system is being done in North Carolina. And what they're doing is they're increasing payments for patient-centered pregnancy homes. That's the kind of model that we're starting to put together for Hera Health throughout the United States to develop more collaborative-based care. As Dr. Nagar and Dr. Peterson stated, we would like to again ask for Medicaid coverage threshold payments and postpartum payments during pregnancy. I'm very happy that we increased from 138% of the poverty level last legislature, I believe, to 165. But still, the U.S. Payment for Medicaid for pregnancy is 200% of the poverty level, 200 to 205%. And although we improved, these are the areas that hurt the people with disparities the most. And since we do have the highest level of Black, non-Hispanic perinatal mortality rates, I believe that spending money in this area is well worth the cost and may even save money down the road. As we also stated, I would fight for the expanding Medicaid coverage to 1 year postpartum. This has been recommended by the American College of OBGYN and SMFM. This really allows for increased chances for follow-up. I think it's like the numbers are as much as 40 to 50% of people, because of the increased problems that they have with transportation and the increased stresses of a new baby, do not make their postpartum follow-up. Or if they don't do it in time, they have a disruption in their healthcare coverage. This affects our marginalized populations the most, and hurts treatment of things like postpartum depression, getting contraception space deliveries a little bit better, opioid use disorder, as was discussed earlier. About 15% of all perinatal mortality or pregnancy-associated perinatal mortality is due to overdose. And that's at the peaks at about the 7 and 9 month period after delivery. These people lose their opioid use cover or use disorder treatment or their MAT treatment and fall out, and hence get overdoses. Again, treatment of these people for the postpartum gives a 2-generation advantage. 55% of all children living below the poverty level have a mother with some sort of depression. Having treatment for them afterwards for up to a year would help alleviate problems with depression that hurts the mother-child bond, which has implications on early brain development. And 1 in 5 people that women in poverty or even higher than that have depressive symptoms, and regardless of income, even 1 in 5 overall. Treatment also gives you smoking cessation treatment after pregnancy and gives you time to put that into place, which would decrease the risk of SIDS. And if you could stop people from smoking, it stops the next pregnancy from problems with preterm birth and low birth weight. And then also postpartum contraception. 1 year gives time to ensure that the child is doing well. It improves birth spacing. And this is super important because 50% of all births in the United States are unplanned, and 80% of them are in people with substance use disorders. Dr. Peterson talked about collaborative care models. What are they? That's when you take services and place them into a regular medical care office. So you might have a mental health treatment into a primary care office. Patients with publicly funded insurance have increased challenges. We just talked about that with transportation. They may have decreased cell phone services. You want to have things in one area, so they have one-stop shopping for for medical and mental health. And this also decreases the stigma of treatment of mental health disorders and decreases the stigma of opioid use disorder treatment. Right now, 1 in 11 people below the poverty level have extremely severe depression, and only 30% of them seek help. If they're going to a medical visit, this allows an opening of that door for treatment for these people overall. And then again, this is a money saver. Treatment of each mother with a perinatal mood disorder in the United States, from a recent article in Health Affairs, shows savings of about $32,000 a year, or $32,000 over 5 years for the treatment of the mother and the child. Opioid use disorder, like we said, people get problems of overdoses after delivery. We really need to have behavioral health for after delivery, but also during delivery. Our office runs the MOTHER program, which is the Maternal Opioid Treatment Health Education and Recovery program. We treat with buprenorphine, and we've only had a 5% NES rate, where the national rate is 55 to 60%. We work by a behavioral health model that is a collaborative care model, but we can't bill for it because we can't pay for it. To pay for these services, we can't bill for them. We have been lucky enough to receive grants, but grants are only a temporary stepping stone. We need to be able to pay our care managers and recovery support counselors. Collaborative care models really integrate these services overall, and like I said, they decrease the stigma, they build on existing provider relationships, and they decrease the social determinants of health by creating one-stop visits. We really need to have collaborative care paid for by Medicaid. One of the last side notes I will tell you that I think would probably be unexpected to you is we have a very deregionalized system of care within Nevada. In Clark County, 8 of our 9 hospitals that do deliveries have level 3 NICUs or above. This is way too many. And when you have way too many higher level of care hospitals, what happens is you decrease the experience at each hospital, especially when we have a healthcare worker shortage. It's been shown in the Vermont Oxford database that if you do less than 50 very low birth rates of deliveries per year, if you have less than 50 in your unit, you have an 11% increase in neonatal death. Another article showed that as many as 1 in 30 babies that delivered in a low volume NICU dies unnecessarily from not having the higher levels of care from experienced people. Another research article showed a risk-adjusted odds of adverse outcomes such as severe breathing problems, bleeding into the brain, blindness was 16 to 55% higher among infants at hospitals with lower than 50 very low birth weight deliveries per year. Within Reno, we have a 3rd hospital that's just opened up, but the 2 other hospitals in the Reno area have level 3 NICUs that do deliveries. And it is the plan of the 3rd hospital also to have a level 3 NICU. That would make 11 hospitals in the state with level 3 NICUs. And there are only 436 very low birth weights in all of Nevada in 2020. Hence, a majority of them are doing less than 50 deliveries a year, which probably lead to worsening outcomes. Our hospitals, how do you solve this? Do you look at a volume indicator? Do you look at the very low birth rate mortality? Very hard to say, but hospitals in the highest 20% of mortality usually tend to stay there, and the ones in the lowest 20% usually tend to stay there, and you might want to make judgments based on that. The last thing is when you have all this deregionalization, we have an OB shortage and a maternal fetal medicine shortage, and you're spreading these providers out all over different areas, which exacerbate the problems of maternal care overall. So overall, my final ask is for funding for perinatal quality collaborative urgently. I think we got sidetracked last time because of the coronavirus outbreak, and I would urge you to help us move forward to help our patients within Nevada. I think we need changes in global pregnancy funding to help reverse our shortage of providers in Nevada. I would ask for a Medicaid coverage threshold to be increased more towards the national average of 200%, which would assist our mothers with social determinants of health and other disparities. I would ask for expansion of Medicaid coverage to 1 year to help with birth spacing, help with treatment of mental health disorders, help with treatment of opioid use disorder. I would implement policies or ask for implementation of policies for behavioral health services and OBGYN offices, maternal fetal medicine offices. I would ask that you mandate state Medicaid to pay for collaborative care services. And then I think we have to look at this explosion of level 3 and level 4 NICUs in our state that have deregionalized care, helps to produce more worsening outcomes, dilutes healthcare experience at each center, and exacerbates physician shortages. With that, I'll end.
Thank you so much. That was a lot of information, and really appreciate that summary slide at the end, summarizing the asks. Are there any questions from the committee? I have Dr. Titus up here who has a question. I'll go ahead and start with you.
Well, thank you for the presentation and totally unexpected information that you presented at the last slide, especially regarding the excess in facilities, diluting care and maybe worsening outcomes. I'm going to ask a question about that in a minute, but first I'd like to go back. You didn't have any numbers on your slides, and I was wondering about that one statement and just a clarification that I heard correctly. You mentioned that 50% of pregnancies were unplanned and 80% of those had substance abuse involved. Did I hear you say that correctly?
Oh, no, I'm sorry if I stated that incorrectly. It's 50% of pregnancies within the US are unplanned In mothers that have opioid use disorder, 80% of them are unaccounted.
Okay, thank you. Thank you for that. And then let's go back to your closing statement there regarding the number of facilities in Nevada. In the healthcare realm, we have something called a certificate of need when you're applying for licensure. And you have, so to prevent the excessive applications like CT scans, MRIs, care flights, et cetera, even hospitals. I thought there was some limitation on who could get licensure based on this certificate of need. Can just any hospital, when they put in a NICU? I did training as a family practice doc in the NICU in St. Mary's and at Washoe at the time, because I was doing deliveries and needed that experience to save them out in rural Nevada if I needed to. So I'm just curious as to how this is expanded, and is there no regulation on the numbers of the NICUs that we have?
Generally, what's needed is you need a certain volume of deliveries to be able to apply for a NICU increase in level of care. The thing is all you have to do is show that you have certain equipment and certain personnel to be able to open a NICU at a certain point in time. And there is a lot of burden to do that. So I don't want to underestimate that. There's a lot of burden to do that. But the certificate of need overall for the community, from a community standard, is really not the case. That really doesn't hold and doesn't move forward. As you can tell, I mean, just from the very low birth rate babies alone, you could show that that need isn't there. And what I would say to you is it's because of a profit incentive, I believe, for care of neonates. If you look at hospital-based systems, the most profitable areas in hospital systems usually are the cardiac cath lab, the orthopedics operating room, and second or third is always the NICU. So there's a financial incentive to open a NICU, but at the same time, this is creating other sorts of problems along the way. And I can see Dr. Nagar wants to get in here quickly because she got back on her camera, so I'll let her do that.
I can't agree more with Dr. Irier about the importance of quality care being the importance instead of quantity of care. Similar challenges happen when increased NICU, level 3 NICUs are in place because for level 3 NICUs, the physicians stay in-house. So the shortage also continues to be a challenge for the neonatal world to provide that in-house coverage 24/7, and then have this dilution of care because of the limited services, not only in the hospital, but also subspecialty coverage across the board, with anywhere from GI, surgery, neurosurgery, neurology. Every single one of them are having to go to multiple hospitals, and it does dilute that care.
Follow up on that, Madam Chair. So just again, just to be clear, if we have 11 NICUs or potentially 11 NICUs, but there's 3 new ones coming in Reno, they can only get licensed to do that if they can staff those NICUs. And so, and which means they would have to either bring doctors in or share doctors, but again, they can't be licensed if they can't be staffed. So why would we want to limit accessibility to healthcare when we know across the board we don't have enough docs in Nevada? So I'm just curious about that one. My first question. Second one on that one is, are all these that have the NICUs, soon to be 11, Medicaid reimbursed ones already, or are they just all private facilities? Do you have a breakdown on that?
They all accept NICU in one way or accept Medicaid in one way or another. Some institutions only accept certain forms of Medicaid, but all of them accept one or another form of Medicaid, and most of them accept all the Medicaid HMO plans. In regards to the staffing numbers just say you need a certain number of personnel. It doesn't tell you how experienced that personnel is. It doesn't tell you how they keep their experience by dealing with more intense, severe cases all the time. It doesn't tell you the nursing experience or quality. It just tells you numbers. So you can get by that by being able to hire personnel and train personnel for those positions, but it doesn't mean you have already trained, experienced, high-level care in each institution.
Thank you for the questions. Are there other questions from the committee? I see Assemblywoman Gorlow, please go ahead.
Thank you, Madam Chair, and it's good seeing you again, Dr. Urier. Some people might not realize we already have some maternal and child health coalitions and advisory committees already in the state. So could you talk a little bit about how this would be different from what they're already working on?
Are you talking the Perinatal Quality Collaborative?
Yes, the difference on how the Perinatal Quality Collaborative would be from the MCH Advisory Committee or any of the 3 coalitions that are already in place.
They would really be the organization that puts together and solidifies the marketing, the education, the data-driven response, and the implementation from a research perspective. As I showed, what perinatal quality care collaboratives have done when set up in this fashion have really decreased morbidity and mortality. And you really need a centralized structure to be able to do that. Those structures are usually assisted by an organization called NEACHQ or NNPQC, which is Neonatal Perinatal Quality Care Collaborative Society in the United States. Those are federally funded organizations that put these programs together, make sure that they're run at a high level and utilize educational and research perspectives that are basically best practices.
Thank you very much.
Thank you, Assemblywoman Gorlow. Anyone else have questions for Dr. Urier? I'm not seeing any. Thank you so much for the presentation again. Really appreciate it and your time. And we'll go ahead and close that agenda item. At this time, we're doing pretty good on time, y'all. We are going to take a lunch break, 30-minute lunch break. There is food in the Grant Sawyer building there for y'all, and we've got some up here, so shouldn't have trouble getting to that. And we will see you back here at, let's see, 12:45. So a little extra time, a half hour. Okay, thank you all.
Okay, we are going to stop this share. We'll be back. They'll be back at 12:45. And will we?